Good morning, honorable members. Good morning to the Department of Health. For those who have logged in, good morning to the officials and leadership of Council for Medical Schemes, to our staff members who are here too, and other interested parties. Good morning to you all and welcome. May we start by a moment of silence, and for those who were here yesterday, we also still continue to give our condolence to the Catholics in the world and in our country, and maybe in this platform, for the loss of the leader of the Roman Catholic Church. Just a moment of silence, honorable members. Thank you. Okay, thank you very much. We are today meeting once more to go through our work as a portfolio committee of health. Honorable members, just as a reminder that this meeting, though virtual, is assumed to be taking place within the precinct of Parliament, and therefore will be conducted according to the parliamentary rules and processes thereon. And I would want honorable members to just make these a few requests to you and for your consideration, things that we have just been discussing with the chairperson, with the portfolio committee secretary. Number one, we've just received the news that there's been a second fire at Tembisa Hospital this morning, and therefore it would really be a bit of a irresponsibility for us not to comment about that, but a comment about that hospital would only be possible if we have been to that hospital. So it's a short notice, but we request that we don't interfere so much with your weekend, but we cannot avoid not to go to the hospital on Gauteng on Friday. I am requesting that as we are in this meeting today, you start contacting through your Zoom, through your WhatsApp, the staff, as to whether you could be able to fly tomorrow afternoon for those who live outside Gauteng, or you fly on Friday morning. Part of that I'm going to be requesting, and I'm sending it now to the minister, that we request that
recording in progress.
We request that our meeting tomorrow starts at 1 o'clock instead of 2. We have to then quickly dash out from our caucuses, if parties have got caucuses. The meeting has been converted to virtual. So we'd like to start at 1 o'clock tomorrow. In the event we are able to finish 3 or 3:30, 4, and then for those who are outside Gauteng, be able to take flights if there are still flights available at 5, 6. It may be a bit convenient for most of us to sleep in Gauteng tomorrow evening. Maybe in the airports, I'm sure the staff will not have to take us that very far. Just land and sleep, and then be able to proceed the morning on Friday. Through the advice of Honorable Clerk, it may just be a good thing now that we're in Gauteng to visit Tembisa Hospital and just maybe pop in at Rehama Musa Hospital. If we do that, we still would have to meet with the MEC HOD in the afternoon, and therefore there may be challenges for some flights to leave on Friday evening, and therefore request that some members be accommodative to sleep again in Gauteng if flights are not available after 4 to travel out of Gauteng. We do this, honorable members, knowing that there might be plans for weekends, so at least you interfere with your weekend a bit rather than to have a visit at this hospital on a Saturday. So we are really squeezing the Friday so that we still can have a weekend free, because members might have had plans already. It's a long weekend coming through. May I therefore say, honorable members, I take this as a suggestion that will be agreed upon. If we are not 10 of us going in there, but a handful of us, 5, 6, 7 might go, please indicate your availability to the team, to the staff. I would also like to see how many of us, if maybe we can just send this message as we start our meeting now on our WhatsApp group. It would help us greatly. And also indicate where would you like to be flying from. Number two, whether you would like to fly tomorrow evening, or you could only come in at Friday morning. But at least by 9 o'clock, we should be leaving the airport if we are sleeping around the airport on Friday to start our visit to Tembisa, which is not very far from the airport. And then also take Rehama Musa, and probably by 1 o'clock, we should be meeting with the MEC. May I request, therefore, that honorable members indicate your availability on the logistics of this now as we start our meeting. Thank you very much. To Dr. Thandi Mabeba and Dr. Musa Gumede, welcome. Thank you very much. Leadership of the Council for Medical Schemes. We are here to listen to your plans, annual performance plans, and together with your strategic plans and the budget. And we would allow you to have 45 minutes of presentation or less. Thereafter, committee honorable members will interact with your presentations, and then thereafter we will come back again to support us with your responses. So we would wish that at least by 10 to 11, we are wrapping up our interactions with you. So your time starts now, introducing yourself, and therefore Chair doing your own opening remarks, and then take it from there. Over to you now. Or maybe before that, Ms. Machalamba, just to confirm, I just started the presence of the members here so that it's recorded also, because the meeting is recorded, to just indicate to us the members that are here, honorable members that are joining us.
Good morning and thank you, Chair. Present is Dr. Lomo, Ms. Keko, Ms. Sine, Ms. Clark, Dr. Leroux, Mr. Mutubati, Mr. Mujadu, Ms. Mailola, Mr. Van Staden, Dr. Litlape, and Ms. Msongo. I haven't received any apologies yet, Chair. Thank you.
Okay. Okay, thank you very much. We do have a full house today, and we would really request that our members do, just like yesterday, engage and reach the discussion and all our thoughts. Over to you, Dr. Thandi Mabeba and your team. Thanks.
The Honorable Chairperson of the Portfolio on Health Committee, Dr. Sibongiseni Dlomo, Honorable Members of Portfolio on Health Committee, members of the National Department of Health present, distinguished guests, I greet you all. The Council for Medical Scheme is delighted to have been invited to share its strategic plan 2025-2030 and annual performance plan 2025-26 to the Portfolio Committee on Health. Chairperson, I am not alone. With me is the Deputy Chair of Council, Dr. Mkara, in his absentia, our new CE and Registrar, Dr. Musa Gumede, the Acting CFO, Ms. Victoria Letwalo, the Executive Committee present, and Chair, without departing from the main objective of the presentation today, which is to brief this August committee on the CMS, APP, SP, and budget to ensure oversight, transparency, and accountability. I would like to share my slides. In the interest of time, Chair, I would like to briefly highlight to the Portfolio Committee our noticeable development and attainments, as well as a brief touch on who we are and the industry we regulate. The entity has achieved an unqualified audit outcome. It is 89.47 overall organizational performance, the 5 PMB definition guidelines, and released 12 research studies, as well as 52 annual general meetings observed in the industry. The Council for Medical Scheme is a creature of statute established in terms of the Medical Schemes Act number 131 of 1998 to oversee the private health financing sector in order to ensure that medical schemes operate in a fair, transparent, and financially sound manner while safeguarding the interest of the beneficiaries. Our legislative mandate is derived from the Bill of Rights contained in the Constitution, particularly Section 27 of the Constitution, which guarantees everyone access to healthcare services, including the reproductive health care. Furthermore, the Medical Schemes Act establishes the Council and outlines the powers and functions of the Council. These functions are contained in Section 7 of the Medical Schemes Act. At the center of the functions of the Council, as provided for by the Act, is the Council's mandate to protect the interest of the beneficiaries, of the members of the medical schemes. The Council adopted an organizational higher statement to align with international best practice guideline for governance of organizations, which places purpose as the foundational principle for the governance of all types of organization. And our organizational higher purpose statement is to regulating the good governance of medical schemes to sustainably protect the interest of members, beneficiaries, and other affected stakeholders. At a higher level, the industry statistics as at the end of 2023-2024 financial year indicate that members' distribution remain largely unchanged over many years, with under 16% of South African B members of the medical scheme. The CMS oversees over approximately 9 million lives enrolled in 71 medical schemes. Financially, the industry continues to demonstrate robustness, collecting 226.94 billion in revenue and disbursing 217.59 billion in claim payments, with a solvency rate of 43.45. The industry maintains a healthy financial position. This slide demonstrates the Council for Medical Schemes' effort to empower beneficiaries and increase visibility of the CMS. Chairperson, the slide order is changed a little bit. I will go straight to the strategic plan and I'll revert back to the slide that was projected. The revised strategic outcomes for the 2025-2030 MTDP period talks to the 6 strategic outcomes. In essence, the 6 strategic outcomes are designed to create a well-functioning, equitable, and sustainable private healthcare financing sector that complement the public health system and contributes to the broader national health and development goals of South Africa. The focus on regulation, access, quality, efficiency, good governance, and evidence-based decision-making position the CMS as a crucial entity in the South African healthcare landscape. Outcome number 1, which is regulating entities in compliance with national policy, the Medical Schemes Act, and other legislation. In the main, Chair, this outcome establishes the CMS as a vigilant guardian of the medical schemes industry, focused on ensuring legal compliance and protecting the interests of the scheme's members through efficient and effective regulatory processes. The indicator provides a means to assess the CMS success in fulfilling this crucial mandate. Outcome number 2 is to promote access to quality, cost-effective, affordable private healthcare financing and related private healthcare. Outcome number 3 is to encourage risk pooling and innovation for the effective functioning of the private healthcare financing sector. This outcome focuses on strengthening the private healthcare financing sector through 2 key strategies: the risk pooling and innovation. The outcome statement outlines specific actions the CMS intends to take to enhance risk pooling. These are standardizing scheme options, consolidating medical schemes with less than 6,000 members, consolidating government-funded schemes, developing and implementing a comprehensive primary healthcare benefit package. The statement also emphasizes a consultative approach that recognizes the importance of engaging with various stakeholders to ensure that strategies for risk pooling are implemented in a way that considers their interest and potential risk. The outcome indicators offers specific measures to track progress towards this strategic outcome. A new base benefit package for PMB is an outcome indicator for this outcome statement. Enable consolidation in the medical schemes industry, as well as the number of draft benefit definition guidelines. In a nutshell, outcome 3 focuses on strengthening the financial stability and efficiency of the private healthcare financing sector through deliberate efforts to enhance risk pooling via standardization and consolidation, alongside the development of the comprehensive primary healthcare package benefit. The indicator provides tangible ways to measure the CMS progress in achieving these objectives. Outcome number 4, stakeholder engagement at local, regional, and international level. And outcome number 5 talks to good governance and ethical leadership. This strategic outcome centers on enhancing the internal operations, and leadership of the Council for Medical Scheme. The outcome statement highlights several key areas of focus: reviewing, updating, developing and implementing policies, strategies, and SOPs, improving organizational effectiveness and efficiency, promoting ethical and effective leadership through training and policies. Ultimately, Chair, this outcome aims to build a strong, well-governed, and ethically driven organization that effectively regulates the medical scheme industry. The outcome indicators offer specific ways to measure the Council for Medical Schemes' progress in achieving good governance and ethical leadership by ensuring that the entity is consistently achieving and improved audit outcomes towards a clean audit, and that the fraud, corruption, and consequence management cases indicator focuses on the CMS ability to detect, address, and manage instances of fraud and corruption within the organization. A decreasing number of such cases and evidence of consistent and appropriate consequence management will indicate a strengthening of ethical conduct and internal controls. In the main, the outcome number 5 emphasizes the CMS commitment to strengthening its internal governance structures, enhancing operational efficiency, and fostering ethical and effective leadership. The indicators provide a means to assess the CMS success in building a robust and trustworthy organization. The outcome number 6, conducting policy-driven research, monitoring and evaluation of the medical scheme industry to facilitate decision-making and policy recommendations in the health ministry. The refocusing of CMS research efforts and aligning them with the policy developments in the public and private health sector will ensure that this outcome is achieved. The outcome indicator may include number of policy-driven research projects undertaken and completed, a number of policy recommendations submitted to the National Department of Health, evidence of the Council for Medical Schemes research and monitoring informing decision-making within the organization, evidence of the Council for Medical Schemes policy recommendation being considered or adopted by the National Department of Health. I will quickly go back, Chair, to the previous slides that talked to the key strategic issues and briefly touch on them as they are of public interest. The committee may be aware of the draft health interim block exemption that has been published by the Department of Health in collaboration with the Trade, Industry and Competition Department for public comment. This draft seeks to promote collaborative practices among healthcare providers and funders, particularly in the context of economic challenges and healthcare system reform, while ensuring compliance with the competitive law. The low cost benefit option, as the Honorable Chairperson and the committee members may be aware, that the Department of Health has opened the LCBO report to the public for comment, inviting various stakeholders to submit their inputs by May 12, 2025. But it is also worth noting, Chair, the Gauteng High Court ruling, which dismissed the BHF application that sought to compel the CMS and the Ministry of Health to implement the LCBO sometime last month. As it pertains to the demarcation framework, Chairperson, has been extended for an additional 2 years. Chairperson, I would like to highlight the alternative funding model. A more strategic approach is essential to ensure the organizational long-term financial sustainability. This has been previously presented to the Honorable Chairperson and the committee. And lastly, Chair, relates to the Section 59 report. We have been informed that the panel of the Section 59, 2 of the members of the panel of the Section 59 have been in a position to complete and sign off on the report, and the report awaits the final signature from the chairperson of the panel, whom we are awaiting to sign and therefore receive the report. Chairperson, as I've mentioned, in the interest of time, I wish to thank yourself, Chair, together with the honorable committee members for the opportunity. I am going to request the CE and registrar, Dr. Gumede, to take over. And thank you so kindly, Chair.
Thank you, Chairperson. I would like to indicate that, as the Chairperson has already alluded, CMS has adopted the 6 strategic outcomes, and we have therefore packaged our work into programs. We have 4 programs that outline how we are going to work. And these programs are Program 1, 2, 3, and 4, with Program 1 being the administration program with 28 indicators, 4 of which are new. Program 2 with 14 indicators. This is the main thrust of the organization, the regulatory program, with 3 new indicators in the program.
Dr. Gumede, we don't see you.
Can I ask the slide that shows indicators as well to be shown? Thank you. This slide as well. Thank you.
Okay.
This Program 2 is the regulation, which is the thrust of our work, and it has 14 indicators, with 3 being new. We then have Program 3, which is member protection, which has got 10 indicators. This is where complaints and clinical guidelines are developed and customer care takes place. There's no new indicator this financial year. And then the last program that we use in order to implement the 6 strategic areas is the research and monitoring program, which has got 6 indicators and 3 of those are new. So we have 58 indicators that we monitor in order to meet the performance of the organization. Chair, because I'm remote from the team, the meeting took place while I was away from work. I have an acting registrar, Mr. Baloi, who will then take us through these 58 indicators in detail. And also we have an acting CFO who will then finalize the presentation with our financial standing at the moment. Mr. Baloi will then take us from this slide forward. Thank you.
Chairperson of the committee, honorable committee members, colleagues from CMS, and other colleagues joining from other entities. I will be going through the details of the APP. This APP is the inaugural, the first APP of our new strategic plan, 2025-2030. I will run through it in the form of a marathon, starting with the indicators in the program 1, which is basically made of the Office of the Registrar, including all the support functions, namely finance, ICT, corporate services, and the company secretariat. Of key of the indicators that are in the Office of the Registrar is the development of the MOU, which is aimed at strengthening relations with the stakeholders, but also from a compliance point of view in terms of the PFMA, we are expected to submit a strategic plan and also an annual performance plan on an annual basis to achieve the strategic outcomes. We are also responsible in that program to do performance information that must be submitted to the executive authority, including tabling to the legislature. So those indicators, committee members, are mainly compliance documents that are for submission to the executive authority and the legislature. Following is the Office of the CFO, which outcomes are based on good governance and clean audit. We have an indicator that speaks to the clean audit that must be achieved by the entity. We have intentions to develop a funding model, which work we are doing in tandem with the National Department of Health. Equally important is the approval of the budget that allocate resources to all the programs of CMS. We have the sub-program ICT, which is 1.3. Key to that sub-program, Chairperson, is the focus on modernization, on digital transformation, cloud migration, and ICT governance. The indicators there that are very prime. One is an indicator on the availability of network systems, the running of all business applications across the programs that are administered at CMS. We have an indicator that speaks to the backup. We have an indicator that drives our digital transformation in line with the policy trends within the ICT space, including the major shifts in the digital platform. We have got an indicator that speaks to the modernization of the ICT applications, including the ICT governance. So all these indicators, Chair, as we have seen, we have pronounced on targets on a multi-year basis, including the current, performance cycle up to the outer year, which is 2026, 2027. I will then cross over, Chairperson, without time, to talk to corporate services sub-program, which is mainly composed of legal services, human resources, communications, and facility management. Of key indicators is our indicator that speaks to supporting the entity in terms of the legal services provision, production of legal opinions, defending CMS in legal matters, managing litigation, making sure that there's proper legal advisory and litigation management, and ensuring that there's an appearance in all judicial structures on behalf of CMS. Key to the indicators that are for corporate services, those indicators are mainly HR governance and compliance matters. We speak to matters of staff turnover that we think have got to be retained below 15%, the vacancies that must be filled within 90 days, the issue of attending to staff performance agreements and staff assessments, making sure that there's a 95% compliance submission in those areas. We also have indicators that make us interface with our stakeholders. These indicators, Chair, relate to matters of awareness, industry engagement, communication strategy, stakeholder relations. So all those efforts are intended to make sure that CMS is visible to the public and the entire industry, because this matter has been raised on various public platforms, including the portfolio committee, with regard to our efforts to improve the visibility of CMS. Then lastly, Chair, under that program of corporate services is the deliverable on ensuring that we are able to produce an annual report as an entity that we must submit to the executive authority, including tabling to the legislature and the specific portfolio committee, which is yourself. Then we have the Council Secretariat, whose main role is really to support the accounting authority, including its subcommittees. The indicators in that sub-program, Chair, they speak to the timeous circulation of council documents, packs, to ensure those documents are received by council timeously, to allow council to engage extensively in discussions on matters that pertains to governance of the entity. We've got an indicator that speaks to the minutes of council, the turnaround times within which they must be submitted. We have also got a resolution, an indicator that speaks to the archiving of council resolutions and management of those particular resolutions. We have got an indicator that speaks to the empowerment of council members or the governance members, because in terms of the King 4 report and other public service governance framework, council members are supposed to be empowered and trained. Then the last indicator, Chairperson, in the Council Secretariat is to administer the annual declaration by council members, which seeks to address issues of the conflict of interest. So I will then move, Chair, to the core divisions, starting with the division regulation. As I've indicated, this division deals with accreditation, compliance, investigations, and other related regulatory functions. The first indicator, Chair, pertains to the accreditation of brokers. We've put in indicators of 85% accreditation rate in the current financial year, including the autumn financial year, and the spread across the 3 years. We've got also the accreditation of managed care organization, which is target, which is spread across the current performance year, including the outer years. we have got indicators that speaks to the annual schemes rules amendment. We've got an indicator that talks to the annual contributions approvals that must be done by CMS on an annual basis. The indicator that speaks to rule model revised processes. Then key to this program of regulation is the conducting of inspections of the regulated entities. We've got the commissioned inspections that we conduct, including the routine inspections that we conduct annually. For this performance year, we intend to conduct 10 routine inspections, then convert that to a percentage for the outer year to be reflected as 80% moving to the next 2 years over the medium-term expenditure framework. We have got also an indicator on the schemes governance interventions, which indicator is driven from compliance and investigation subdivision within the branch regulation. Then we also attend the AGMs of schemes where we monitor them on an annual basis to ensure that their governance arrangements complies to the Medical Schemes Act, including the regulations. We also approve the business plans and make sure that those are in line with the Medical Schemes Act in terms of ensuring that there's an appropriate financial soundness of medical scheme. Then, Chair, I will then move to program 3, which is basically member protection. As the Chair has and CE has indicated that this program is at the heart of CMS. It is a frontline service where we deal with walk-ins, telephonic inquiries, online inquiries, and we interface with the public directly in terms of responding to their inquiries and complaints. The first indicator, Chair, it's an indicator that deals with education programs, training sessions, awareness programs, advocacy programs, where we are informing and empowering members of schemes about their rights and obligations. So for this current performance cycle of 2024-26, we intend to have 60 sessions that are crossover to the 3 outer years of the medium-term strategic framework period. Then, Chair, we also have got an indicator that speaks to the customer care interventions that must be maintained at 90% in the current performance cycle. We also speak to the resolving of member complaints. These complaints are categorized in various categories, which is category 1 and category 2, to make sure that a performance of above 75% in the current performance cycle and the outer years, that target is maintained in terms of resolving member complaints. We also deal, Chair, in this program with the publications of CMS scripts, dealing with clinical opinions that are provided as part of supporting the resolving of complaints, but also responding to the clinical inquiries within the timeframes that are indicated as targets, as you see in the screen. Then lastly, Chair, program 4, which is the intellectual hub of CMS, we have got 6 indicators there. The first indicator speaks to the number of standardization of standardization of options implementation report. This indicator, Chair, is a response towards the HMI recommendation that has made a recommendation that as a regulator, we must consider developing a standardized option that will cut across all the schemes and industry at large. So this indicator seems to respond to that recommendation of the health market inquiry. These also include the responses to the NHI. Then we have got the PMB review, which we are expected to review on an annual basis as required in terms of the Medical Schemes Act, but also produce PMB guidelines on an annual basis. We are also considering, Chair, as a new indicator, the consolidation of the medical scheme indicator. This will apply to schemes that have got less than 6,000 members. This is done for purpose of ensuring that there's a sustainability. Already, Chair, CMS has already commissioned a study on the public sector schemes, namely GEMS and POLMET, where we are looking at the possible consolidation and proposals around the public sector medical schemes, and the recommendations have been made in that regard, and those recommendations will also be implanted into this specific study of the consolidation of the medical schemes. Then I've already spoken, Chair, about the indicator on the benefit definition guidelines, which is the work that we do on an annual basis around the broad areas of the PMB. Then we've got a number of research projects, Chair, that we intend to roll out during the current performance cycle, including the outer year. Of key to these projects, Chairperson, is to make sure that we are able to advise the minister, the department on various national health policy issues, including the NHI. Already, we have tabled a report to the minister that has been submitted, which is the LCBO, which is currently out for public comment. Then lastly, Chair, in this program is the development of the industry report to look at the non-financial trends in the expenditure of the medical schemes finance utilization report, which report we present to industry on an annual basis, Chairperson. So in totality, Chair, as the registrar has indicated at the beginning, we have in total 58 indicators for all the 4 programs. We have tried to trim them down and move some of the indicators to the operational plans. So, Chair, I'm going to pause here and allow the acting CFO to take us through the budget and the financial information.
Thank you, Chairperson. Thank you, Mr. Baloni. Let me first start by greeting the Chairperson of the Portfolio Committee and all the honorable members. Chairperson of Council, Dr. Mabipa, the Registrar, Dr. Musakubete, the Executive Management present, members of the Department of Health, and other entities present. I'll be very brief, or try to be as brief as possible, as I'm taking you through the financial information. For the 25-26 MTF period, our assumptions are based on a proposed levy increase of 6%. Our tariff-based revenue
is as per regulations that speaks to accreditation and registration fees. Yeah, our grant-based revenue, which is about 6 million a year, which is a 3% increase from 24-25 in the current financial year. Our cost of living adjustments, which is based on CPI of 4% for the current year, which is for executives, and then for the rest of the employees, it's a CPI plus 1%, which is 5%. We've also budgeted for a performance-based increase of 1%, a 1.5% per annum notch progression, as well as a 5 million performance bonus. The new budget also includes 3 new positions, which have been budgeted for. And then for goods and services, the CPI inflation, we've got 4% for 25-26, 4.6% for 26-27, and 4.5% for 27-28. In terms of consolidated budget for the 25-26, we have a budget of 238.6 million for both salaries, goods and services, and capex. And then our revenue is mainly based on the levies of 213.9 million, which is a 6% increase on the prior as indicated. If we speak to the detail of the revenue, as you can see, accreditation fees is about 9 million. Interest has increased to 8.6 million based on the trends for the past few years. The government grant goes up to 6.3 million and the levies are spoken to. So our total budget is 238 and we are not budgeting for a deficit. In terms of the economic classifications, COE is 170.89 million, which is about 72% of our total budget. Goods and services is about 63.78 million and capital expenditure is 4 million. This is based on affordability and this is mainly for ICT reinvestment. And then this is the detail of the economic classifications. I will not go into detail. The biggest expenditure, if you can see there, is for the lease for our building. And then we've got our computer services, this is software licenses and such, internet expenses. We've got property payments, which is our security, the levies and electricity, and then training, which is about 2.5 million. And then our board cost, which is about 5 million. This is the end of my presentation. Thank you. I'll hand back to the Chair of Council.
Thank you so kindly to the registrar and Mr. Baloyi, who stood in for the registrar together with the acting CFO. And thank you so kindly, Honorable Chairperson and committee members. We hand over back to you, Honorable Chair, for your further guidance.
Oh, yes, thank you very much, Dr. Thandi Mabeba. Before we move on to raise questions with you, it's me and you, we both forgot that you have a new registrar who has not been introduced to us before. Can we allow you to do that part while I'm recognizing the hands? I don't remember seeing Dr. Komete in this platform. Let me not steal the thunder from you. I know him from some other places. Please introduce him to us. Thank you, Doctor.
Thank you so kindly, Honorable Chairperson. Indeed, Chairperson, this is one of our success. In the previous presentation to yourself, Chair, and the committee, we did indicate one of the issues that we're facing the entity, which were the recruitment of the new CE and the fact that as an entity, we are to develop a new strategy that will cover 2025-2030 fiscal years. We are happy to introduce our esteemed member, the Dr. Musa Gumeda, who has got a very good track record in the industry as a leader in various platforms. He joined us from the 2nd of December 2024, and he has been with us for about 5 months. He unfortunately had taken leave when the Portfolio Committee on Health invited this entity to present the SPAPP and the budget, and had to request one of the executive managers through council to stand in for him. He is Dr. Gumede. Dr. Gumede, you are most welcome. You may wish to greet the Honorable Chairperson and the committee members. And if we have one or two words to say about yourself, you're welcome to do so. Thank you so kindly, Honorable Chair.
Yes, thank you very much. We can give the opportunity to Dr. Gumede to say something about him, where he comes from, what is he coming to do here, take us to greater heights. Thank you.
Thank you, Chairperson, Chairperson of the Portfolio Committee on Health, and also Chairperson of CMS. I'm humbled to be here. I'm Musa Gumede. I come from Durban. It's where my home is, Mbumbulu. So I sometimes see the chairperson on the road. We use the same roads in Mbumbulu. So that is where I come from. I've worked for the eThekwini municipality as a deputy city manager for quite a long period of time, from 2009. And then in 2017 joined the Department of Health as a DDG there, and also acting head of health. And previously was in the medical schemes industry before 2009. I'm glad to be back in the industry to help the industry move forward. Thank you very much.
Thank you very much, Dr. Gumede. To the honorable members, just to really disclose, I built in Mbumbulu before he came to build in Mbumbulu. I was the deputy city manager of eThekwini before he became a deputy city manager. So he's been the one who's following me than me following him. And I had nothing to do with the recruitment to the CMS, but yes, we are.
Chair, I think your video is frozen.
I also can't hear anything.
Chair, can you switch off the video so that you get a better connection? Can you check on the chair Vyogazi, Miss Majalamba?
Okay.
He went, we missed him whilst he was talking about Imbumbulu, and we know nothing about Imbumbulu as members here. The Mbumbulu news must fall in the meeting.
Hi, Mamtako. Uche is struggling with e-network, so he's requesting that we proceed with the meeting. Thank you.
Can we members take it from where the chair left? I think they were done with the presentation. It was just the introduction of the new members that have joined the council. Can we start by thanking the presenters for such a high-level presentation and start recognizing those that would like to comment on the presentation, maybe asking questions or doing the comment side of it. You will assist us, Vyokazi, in identifying the hands in the order that they will display. Yes, Vyokazi?
The first hand is Ms. Clark, followed by Dr. Leroux, Mr. Mjadu, Ms. Sine, Mr. Mutubatse, and the last one will be Dr. Litlape. So the first one is Ms. Clark, followed by Dr. Leroux, then followed by Mr. Mjadu, Ms. Sine, Mr. Mutubatse, and the last one is Dr. Litlape. Thank you.
Thank you for your Kazi. Thank you, Ms. Machalamba. Can we start with you, Ms. Clark? Can you come?
Thank you, Acting Chair. I'm not going to put on my video because it seems like we've got some network problems. Firstly, I would like to thank CMS for their presentation. And it's refreshing to see that new indicators have been inserted into the presentation relating the health market inquiry outcome. Because that health market inquiry is 5 years old and very little has been done to address that. So I would like to compliment them that they've done that. My first question is approximately 72.8% of the budget is spent on compensation of employees. The CMS reports that CMS currently has a total personnel headcount of 120. This is hopelessly understaffed and relies on interns and temporary personnel to carry out some of its core regulatory functions. What is the current situation? Is the CMS able to recruit and retain skilled workers and compete with the industry it oversees? And how much money is required in terms of budget to rectify this situation? Secondly, the CMS argues that it is understaffed as temporary staff perform certain core regulatory functions. How much more budget would the CMS require for it to be fully effective? And then the CMS should report to the committee on the reasons for the change in programs. Why was program 2, strategy, performance and risk, removed? Then how is the CMS aiming to reduce its legal fees? Please update the committee on any litigation the CMS is involved in. And lastly, the council started a review of prescribed PMBs in line with the health market inquiry. When did this review start and what is the progress? By when will the review of the PHC package be finalized? And when can the committee expect implementation? And then, Chairperson, I just would like to make a comment on an issue in terms of what I was confronted with. So I made an appointment at a gynae and they said they do not accept PARMED. And because of that, I need to pay cash for everything, not just for the consultation, scans, if I have to have a procedure done, all that would have to be cash up front. I mean, is that legitimate in terms of our legal frameworks? Thank you very much.
Thank you very much, Ms. Clark. I hope the delegation is noting the questions as asked by members and also lining up those that will be responding so that you don't lose the sight of questions. Who was next, Ms. Machalamba? Is it Dr. Leroux?
Yes, thank you very much, Chair.
Yes.
My acting Chair. I am back. The lights and the electricity is back. Dr. Leroux is the next one. Please do prepare your slot to ask questions also after Honorable Mjadu, Honorable Sinet, after Dr. Letlape, it will be then Honorable Peko.
Thank you, Chair. Thank you.
Thank you very much, Chair and Acting Chair, and thank you to the presenters from the Council for Medical Schemes. I just have one question around the looking at your budget, 2025-26 budget, and looking at the specifically looking at the lease payments. I see that in the main budget for 2024-25, lease payments were initially listed at 9.9 million. And then the adjusted budget, the lease payments were 15.4 million. That's a significant increase of more than 50%. Why was there that adjustment made? And secondly, paying a lease of 15 million rands a year, I was wondering whether the board or the team had thought about perhaps acquiring a building instead of spending over a period of 4 or 5 years, nearly 50 million rand. So it feels like one could probably purchase a very good building for that price. So I just wanted to get that feedback. Number one, what is that adjustment about? And number two, has there been consideration to acquiring a building rather than leasing a building at those extremely high rates? Thank you.
Honorable Mchatu, you are next.
Honorable Chair, I've got only one question that I want to ask. In terms of member protection, what CMS intend to do for membership protection when funds get depleted or exhausted and private hospital transfer patients to public sector. That's it. Thank you very much, Honorable Chair.
Thank you very much. Honorable Sinne.
Thank you very much, Chairperson, and good morning, everyone in the platform. Chairperson, my apologies, also struggling with network, so I will not be switching on my video. Let me also welcome and appreciate the presentation by CMS and also congratulate them on achieving unqualified audit outcome and also achieving almost 90% overall organizational performance. Chair, my first point, I just want to know from CMS, how did you engage with service providers, payers, and also patients? Sorry, I have to shape 2020. What feedback channels were most effective from that engagement with the stakeholders, and what themes emerged from those particular engagements? And also, Chair, the alignment in terms of the long-term strategy with public health priorities like your pandemic preparedness or chronic diseases. How is CMS aligning its long-term strategy? And then is there any collaborations planned for this financial year with public health agencies or community-based organizations? Thank you. I'm done, Chair.
Oh, thank you very much, Honorable Sinne. Honorable Dr. Letlape.
Thank you, Chair. And congratulations to the new registrar. I've known him for many years, but we don't live in Bumbolo together. And his path has been different. My few questions, some of them will relate to issues of policy. The review of PMB and the linkages to HMI health market inquiry issues. Is there any plan to consider, as the HMI suggests, definition of a basic health package that should be common across all your members. That would ease cost of administration. That would also make it easy for people to know what they are covered for. Now, the concept of medical aid is that members aid each other. But what we find is that people are done like they've taken insurance and they are individually rated. Their funds get exhausted. But other people who are not using the services, they're also waiting for when they are sick and their funds will be getting exhausted. And there'd be no accumulation, despite the issues of medical savings accounts, etc., which are left in the members' hands. What is the council doing about ensuring that there's cross-subsidization and members aid each other so that we can create ease of administration? Now, I've heard that you conduct inspections. Now, medical aids are funders, basically, are handlers of patients' funds. My question is, because part of the issues would be about actuarial work, whether the medical aids are good for the promises that they hold in the promises to members. Do you have any actuaries that work with you when you do your inspections so that they can assess properly the health of the medical aid in terms of its responsibilities to its members? Now, at a policy level, this might be difficult, but I just want to hear from the members of CMS, and I'm glad that you now have competence. There are two things. One, you're now getting into care issues and into guideline issues. Is that part of your mandate, or are you expanding your scope? Should that not be left to health training institutions and healthcare professionals to come up with clinical protocols? Do you interface with them, and whose primary responsibility should that be? Should that be the function of CMS? And if you come up with clinical protocols that people have challenges with, do they then complain to you about care issues, and where do they report that aspect? Just a question of who does what. Just so that you could clarify that. Now, the other question that I have is that, is the NHI not a medical aid? And if it is, why is it not under the jurisdiction of CMS? Because I'm just challenged by the governance arrangements of NHI, where you create a fund that is now going to govern itself inside, with a board that is formed inside the fund. You don't have, like we have now, where CMS is separate from the medical aids, and it has oversight over them. We're now creating a medical aid that's probably going to be one of the biggest in the country, that is self-regulating and self-oversight. And I have serious problems with that. So I'm asking conceptually, help us, because if there's something that needs to be done on governance, it would be our responsibility as lawmakers and as members of the committee to begin to have that discussion about ensuring that there's proper accountability and there's independent structures that can have oversight over some structures. Who has oversight over the NHI and its structures? That, for me, is a concern. And for now, that's where I would like to stop, Chair. I have other questions that I will submit as written so that I do not take too much time, Chair. Thank you, Chair.
Thank you, sir. Honorable Peko.
Thank you, Honorable Chairperson. Let me also join the colleagues in congratulating the council for such an audit report. It is becoming their norm to get the unqualified report. Nonetheless, Chair, I don't have a lot of questions. It's just two. The other one is a comment, but I wanted to comment on the issue of the report that is out there for comments on the low cost benefit option that has been introduced, that is out there up until 12th May, as I get from the report. I think that low cost benefit option, Chair, was going to be an answer to the high tariffs introduced by medical aids. I think now it's becoming very difficult for people to join medical schemes. Even to those that have, it's very difficult to maintain, which I think a medical aid is not a nice to have. It's just a strategy for one. There comes days for one to be sick or needing a medical experience. I wanted to ask that, Chair, because there is this group that took that way was compelling the department to implement such a proposal of a low cost benefit option. But I want them to comment on that. Why is it so expensive? Why are they not negotiating on behalf of the public so that people are able to maintain or join the medical schemes? Also, on the issue of legislation, in the presentation, there is something that talks about that they may be identifying gaps or outdated legislation. Can they make an example so that we are able? Are there any proposals that they have made as a council to the department so that we can take it from there? I want to check on that, Chair. Thank you very much.
Thank you, Honorable Kleko. There's a late hand now, a late hand of Honorable Mutubatse.
No, thanks, Chair. It's not a late hand. I didn't want to interrupt you because when you were in Bumbulu Road, I was listed after Honorable Sinne. But thanks, Chair. To the team, congratulations for the report and also welcoming the Dr. Gumede into the team. What would be your response to a statement that says, I think the indicators, what we have put in front of us on the plate is too much and unbelievable can be achieved? Would that be a fair comment? Secondly, there's an allegation that has been raised that medical aid schemes do not cover tuberculosis. It's only there on paper, but whenever they are confronted with tuberculosis, they secretly hand over those patients to the public institutions because they deem them to be expensive.
That you don't come back again, let's explain. Do not cover tuberculosis. Oh yeah, as a disease when the patient has got it. Okay.
Yes.
All right.
Yes. There's that allegations. I want them to just help us on that. The third one, the consolidation of GEMS and POLMED as you want to. Will it be fair to say that it's a response to the National Health Insurance or an opposition to the National Health Insurance? Will that suspicion be a fair suspicion? Thank you, Chairperson.
Okay, thank you very much. Let me start by saying, Honorable Clerk, I'm happy that they can give whatever the response they could, but I can also assist. As you know, I'm one of those MPs who are board members of PAMED. So the challenge that you are raising, maybe I could also offline talk to you about it and then we see where can you assist. I would like the team to really remind us, not take it, we all know, the Section 59 that is about to be completed. We hear it's almost waiting for the chair to sign it off. if you could actually, not really broadly, but maybe you can write to us and remind us, not all of us as members would recall or have been following those processes on health market inquiry and the reports on section 59. I also want to add on what Honorable Kleko has asked on the low-cost benefit options. I don't know whether I understood it very well. We are proposing that in a strategic plan as one of the possible areas where we could concentrate. And one is saying there's been, one is noticing that there's been a challenge of that, but not successfully in court by another institution. Are you not finding time or weight to explain to that institution what actually were your intentions? Are they able to buy into that space? Related to what was asked by Honorable Dr. Lechape, it would be nice to say how, if you have any information, NHS in the UK migrated from what was there then to where they are now, presence of medical schemes and all that. If you've got any information, we plan that the committee might visit there. I'm sure those are the questions you might ask when you get there. But maybe if you have any insight into that, it will be helpful. We will not be that generous to you. We will still need you to be wrapping up by 10 past, the latest 10 past 11. Thank you very much.
Thank you so much, Chairperson. And I'm going to request the panel to start with yourselves questions, Chair, and then go back to the first honorable committee member, Honorable Clark, who asked questions. Your questions, Chair, will require the legal services and the corporate service together with the senior manager in the legal services to talk to section 59 and also the LCPO together with other questions. Over to you.
Hey, Chair, I would maybe start with section 59 just to give a background to the committee members who may not be aware of the intentions of section 59. The section 59 was meant to probe allegations that were made by medical practitioners. They were at that time, indicating that they are treated unfairly by the medical schemes in terms of race discrimination. These allegations also included the issue of withholding claims due to discriminatory algorithms. Then these complaints had to be investigated. There was a panel that was instituted that has to investigate these complaints. They did convene hearings. Submissions were made from the various stakeholders who were serving as complainants. We did receive the first interim report, while the final report, Chairperson, has taken more than anticipated. And the Council has taken steps to ensure that the panel is driven to release this report. As we have indicated earlier on, that the two members of the panel have already signed the final draft report. And over the Easter weekend, we have been informed that the Chairperson, Advocate Mugai Toby, is in the process of finalizing and to attach his signature to the final draft report. And we anticipate that we should be able to receive that report as urgently as possible. There was a question that was raised regarding the legal fees. I think it was raised by Member Clark. As a CMS, what we have done, we have established a litigation committee internally that seeks to give guidance to corporate services, including the office of the registrar, on matters of legal fees. And one of the interventions that we have done, Chairperson, is the introduction of your alternative dispute resolution, where we are looking at mediation in terms of resolving some of the issues. We are also looking at the judicial processes that are existing, in terms of pre-trial, court proceedings that we use to our maximum in order to reduce the legal cost. And at some stage, I think during the financial year 2021-22, including 22-23, we did see a substantive, reduction using that particular approach. Then Member Clark again raised the issue of staffing issues at CMS. I must confirm that indeed, Chairperson, CMS is severely constrained in terms of being unable to fill all the vacancies in the approved structure. Currently, the head count is around 124, and the approved organizational structure provides for 147. We are unable to fill some of the vacancies given the budgetary constraints that we have. You will have seen in the slide that the acting CFO projected that our COE is almost 69% of the entire budget, which then shows that we are unable as an entity to be able to fill the organizational structure to its maximum capacity. So yes, Chair, I can confirm to say in that regard, we are understaffed and we are severely constrained. Then as an intervention as management, what we have done is to introduce short-term contracts as part of alleviating staff shortages and make sure that we introduce contract employment where necessary. We have asked the question to say, how much are we going to need? We did make a submission to the National Department of Health, and if I remember pretty well, that estimate, Chair, was varying around 50 to 75 million in order to be able to make us sustainable, to be fully, capacitated as an institution in terms of making sure that we achieve our mandate as a CMS. Then to Member Sine, you asked about the issue of collaboration. Yes, we have prioritized, the issue of collaboration. If you will have seen sometime this year, we have entered into a number of MOUs with some of the practitioners associations, health funders associations, NGOs, professional associations, and we intend to strengthen this aspect of collaboration with stakeholders in the industry at large. So I think there were issues that relates to the PMB. I think Dr. Willie will talk to that. I think that was the first question that came from Member Sine in terms of the alignment to the long-term strategy.
Yes, can we have perhaps Dr. Willie followed by the CFO? She has got quite a number of questions.
All right. Well, thank you very much, Chair. And one to the committee members. I'll touch on the question on the PMB, specifically with regards to the private healthcare package. So just a quick update there. So we have done a number, the topic started around 2019 when we requested to submit data on the 10 services that are related to HC. And then last year that was constant, and then we engaged with the industry in terms of the levels of how much it's going to cost, as well as the impact assessment to the industry. So where we are with regards to that work now, it's been constant. We're currently engaging with the stakeholders, including the National Department of Health, and also to seek alignment, because what we have observed is that there is also a PHC that is related to the NHI package. So those engagements trying to see the disparities between what has been developed for the private sector and what can they see in the NHI package. So those discussions are ongoing. And you prioritize that work. I think it's going to concluded this financial year. So should be able to come back to the committee with an update. Hopefully, the alignment of the options. I think the last update was that the minister on the proposal from submitted to them. So despite a lot of progress that has been made there, so far the page has been requested, we're finalizing the consultation process now. So that is one area out of that one. There was also a question related to this on the base benefit package. Yes, it was a recommendation that was made by the NHLS Commission, and it is being prioritized for this financial year. So local traffic is one of the key considerations and one of the key priority areas that in this financial year. In fact, we started working on it last year. So this year there will be a full swing in terms of the consultation. And the focus is great to make sure to on the key pillars from second package. So the answer is yes, there's ongoing work on the key priority area for this financial year. And then there's also the question that's related to the base the benefit definitions. In terms of the process itself, it's an inclusive process of the way we engage key industry players. In fact, it consists of both the medical service providers as well as the medical scheme. So it's a very inclusive process. If I was just to give a simple example, for instance, if the focus of the benefit definition guideline is specific to ENT, for instance, then the main objective there would be to look at key specialists that are primarily focusing on that area. And then what we will do, for instance, we have select specialists that are attractive in that specific area, and we have a committee that will look at the benefit definition guideline. So I think it is within the scope.
Please speak into the mic. We can't hear you clearly.
No apologies for that. So I was saying, am I audible, Doc?
Much better, much better.
Thank you very much. So let me touch on the benefit definition guideline, just to be quick on it. It's an inclusive process, Doc, because what we do, we invite key specialists in that specific area, and then we form a committee which will consist of medical service providers as well as medical schemes, right? And it will be chaired by a specialty in that specific area. And then once the benefit definition guideline is concluded, then again, it goes through another round of consultation until there is consensus, So, but the objective is just to ensure that from the funding perspective, there is some form of standardization. It's done from that perspective. And indeed, the Medical Schemes Act does touch on the essential benefits that needs to be covered by medical schemes. So it does fall within the scope of the CMS. But maybe just to add on the same issue, Regulation 15 is also very specific in terms of formularies as well as clinical protocols that medical schemes need to engage on this, as well as their evidence-based, cost-effective, and affordable, right? So it can be done at scheme level. But what we're trying to do with the benefit definition guidelines, we just want to ensure that from the funding perspective, there is some form of standardization. But the short answer there is that it is an inclusive process that considers both the voice of the medical service provider and that of the medical scheme. And then I think I've covered most of the questions. And then on the NHI, it's a bit difficult one, because the question that you were asking was that why can't the NHI be considered as a medical scheme within the CMS, for instance? I think the difficulty there is that the NHI currently, the process is that it is an act of law. It's really very a difficult one because it's a policy issue. And then we already have the Medical Schemes Act, and the Medical Schemes Act doesn't, in the current form, doesn't make provisions for the NHI. But I think the point that you're making is noted, but I must also indicate it's a complex one. I think a very difficult policy issue, which I think the NDOH could be able to assist to answer that specific question. Thank you very much. Maybe John can touch on it in later stage as well. Thank you, Shane.
Thank you, Dr. I will respond to the financial questions. The first question was from Member Clark on the COE. So currently, as Mr. Baloyi indicated, We had at the end of March 140 officials, but 2 actually resigned and finished work end of March. So we had 138. And in terms of our staff establishment, we have 149 positions that have been to be fully operational. And then we have budgeted, as I said, for 3 additional, but that does not include the 2, the executive in the office of the CEO and the senior manager, strategy and risk. So in terms of the budget shortfall, for us to be able to be fully funded, for the unfunded posts, we shot about 7.69 million. That's only for the 25-26 financial year. For performance incentives, we shot about 12.76 million. And then in terms of retirement benefits, we shot about 8.8 million, which is about 29.3 million just for 25-26. So you need to escalate that by about 7% annually to include the incentives to fully implement our remuneration policy. And then in terms of the question on the lease, so we had to increase the lease budget for 24-25 because initially when we did the budget, we're in the tender process to renew the lease. And then we based it on the bid price that we received, the 9 million. But then subsequently, the lease was not approved. So the addendum to actually stay in the current building, that's the increase that led to the 15 million in terms of the rental. And then the budget for the 25-26 was based on that. But we've now subsequently concluded the lease, so that budget is going to decrease. For the first year, the rental is come down to 9.5 million. So the new lease is starting on the 1st of May. So there will be those savings that we'll be realizing. And then in terms of buying, remember we're a Schedule 3A entity. We do not have sufficient reserves to actually go out and purchase a building. For us to do that, we have to go via National Treasury to get approval to get a loan or a mortgage because that's debt. We can't on our own, on our current balance sheet, go out and secure. It's something that was discussed in council, so we will investigate. That is why the current lease is only for 5 years, not the initial 10 years that we wanted. So we will investigate to say what can we do in terms of us going and procuring our own building. We're looking into that. And then I think I've answered all the questions on finance. Thank you, Chair.
Thank you so much, Chairperson. The next person that will assist us on certain aspect will be the regulation. Talks to LCPOs and
You only have 3 more minutes to finish off CMS.
Thank you, Chair, and good morning, Chairperson of the Portfolio Committee and committee members. There was a question asked by Honorable Dr. Litlape with regard to inspections as to whether do we have actuaries that we use when we're conducting inspections. Perhaps let me start by outlining the kind of inspections that we do. So we have 2 types of inspections. One is a routine inspection, in terms of which we go out to medical schemes to check basically compliance with governance strictures in terms of the Medical Schemes Act and the scheme's own rules and policies. And then we have commissioned inspections. Commissioned inspections are inspections that we do when we have received allegations of misconduct against medical schemes. And those kind of inspections at the moment are largely outsourced. The people that will look for in conducting those inspections will be determined by the kind of allegations that we have that are supposed to be inspected. So it will also determine the resources that we have to use. But over and above these 2, we also do what we call on-site evaluations in terms of which are done under the accreditation unit. This is where we go out and check systems that administrators are using, or which schemes that are self-administered are using, to see if benefits are paid in line with the Act and in line with the rules. Where we do find indications of concerns, we will collect the data and refer it for analysis to the relevant experts that we would need at that particular time. If we need an actuary, that data will be referred to an actuary to do the necessary analysis. We didn't have an actuary in the past, but we have recently appointed one. And going forward, we would look at how we use that resource that we have in the organization. There was a question on LCBOs, whether are they an answer to high cost in terms of medical aid. As the chairperson has indicated, we have done a study in consultation with the medical schemes industry and all the people that wanted to participate in the advisory committees. And based on that, we produced a report which we sent to the minister in 2023. Part of our recommendations based on the engagements was that we don't support the introduction of the low-cost benefit option, mainly because a low-cost benefit option seeks to strip off what we call PMBs, which are prescribed minimum benefits. So we see that as another way of introducing a kind of a benefit which will not provide the cover which people in the need. And as a result, we have said we are not in support of this low-cost benefit option. That report is out there, and the reasons for why we're not supporting are explained in detail in that report. And we will encourage the portfolio committee and the people out there to engage with that report and make their comments to the minister for him to consider, because he wants to be assisted in terms of whether he should be introducing that LCBO or not. But we have indicated our concerns with the proposals at the moment. There was another question with regard to private hospitals transferring patients away from private hospitals to the public hospitals when the benefits have run off. And I think that also it's an indication of what we're talking about, because the challenge or the issue lies in the difference between PMBs and what we call defined benefits. Medical schemes are compelled by law to pay for the conditions that are defined as PMBs, even when the patient has run out of benefits. In fact, when it comes to PMBs, you never run out of benefits. Medical schemes are compelled to pay. But when it comes to discretionary benefits, then you would find that the benefit is defined with a certain maximum, which a member can exhaust. And once you have exhausted, then you end up with a situation where patients are indeed transferred from private hospitals to public and causing a burden. And this is why we say when you check out PMBs, you're leaving members with no protection. Perhaps let me allow the senior manager and now the acting executive in the office of the registrar to expand on this point within the 2 minutes that are left.
No, we don't have expansion anymore. We still have to give to Dr. Tandy to really wrap up.
Thank you, Jane.
Thank you, Mr. Masonga. Thank you, Chairperson. I think I will respond to the question that Honorable Clark raised as to why we dropped the program, the strategy program from our SP and APP. I wish to indicate that this is done to ensure that this function is located within the Office of the CEO or CE and Registrar. As Registrar is responsible for the overall execution of the strategy as directed by Council. After Council approves the strategy, the Registrar is responsible for its execution. And we thought that it is a correct move for us to ensure that we do that. In terms of question that is related to the personal experience that Honorable Clark has on certain benefits not being paid for or in terms of payment. Section 29 of the Medical Schemes Act provides for schemes to have rules in terms of the benefits that are covered. And part of that could include the introduction of DSPs. For instance, a medical scheme may say that for certain benefits, you are required to use a list of designated service providers. And if you do not use that list, then you might find yourself and not covered. But we are happy to look into this matter if our Honorable Member Tag is willing to share the details with our office on member protection so that this matter can be investigated further. I mean, the question that were also raised by Honorable Tlape in terms of what the office is doing in terms of ensuring that there is cost subsidies in the medical schemes and environment. I think it is important to know that the office has always identified the poor, risk pooling in the industry as one of the major causes of escalation in costs. You have seen as the chairperson was presenting that we have 71 medical schemes. This means that these are small risk pools. Because they are small risk pools, they do not have that ability of ensuring that there's effective sharing of risk. That is, you do not have young members joining to ensure that the older members, the prices can be reduced. You do not have a fair balance of the income distribution, ensuring that the high income subsidize the low income. What do you do in that environment? There are strategies. One of them is consolidation, as was raised by Dr. Wheely. Another intervention, which is important, is the NHI, because NHI will then ensure that you have large risk pools, natural large risk pools that ensure that there is fair distribution of risk pools, ensuring that the young, the poor, and the unhealthy find themselves in an environment that they can be adequately covered. I think, Chairperson, the commitment that we can make through the chair is that we will study the questions, and after studying the questions, we'll prepare a formal response that we can then send back to the committee. If there's any question that we've not responded to, we will do that. Thank you, Chairperson.
That would be appreciated. Dr. Thandi Mabeba, your closing comments.
Thank you so kindly to the Honorable Chairperson of the Portfolio on Health. Together with the esteemed committee members, we wish to appreciate the opportunity given to this entity to present its strategic plan and APP together with the budget. We thank you together with the management. We thank you for this wonderful opportunity. And as management has put it to the committee, that in the event some of the questions that were raised by yourself, Honorable Chair, together with your team, will revert back to the committee. This is done to advance and enhance transparency and accountability to your committee, Honorable Chair. We will revert back to you through a written answering format. There was also a question that talked to the TB patients not attended to at the private sector. And I believe we will also answer to such questions. We wish to thank the Honorable Chairperson. A very good morning. Thank you so much.
Okay. No, thank you very much. I'm sorry to have rushed you. The chairperson, the secretary should have reminded me that we stole a bit of your time doing our in-house thing. Nevertheless, we would request you that some of the outstanding clarity comments that you need to make, please do so. Follow them up and send them to us. We greatly want to be enriched by your thoughts and your expertise. So the committee will be waiting to get that. And I'm sorry to have rushed you towards the end of the question time, but we were very impressed with your knowledge in terms of deliberations as you started. A quarter of the presentation was done by yourself as a chair. It's something that is very humbling to see the chairperson really fully understanding the issues of the entity that you have been asked to be supporting. For that, we really thank you greatly. We would then be looking forward to be receiving some of their comments. If there are any outstanding matters that we were not able to get through this platform, send them to our secretary. We will really appreciate that. Thank you a lot. And we will now use you now. Thanks.
Thank you so much, Chair. Thank you so much.
Yeah. Honorable members, as you are grabbing your cup of tea, coffee, we'll give you 5 minutes to do that. Please continue to respond to our parliamentary staff with regards to the logistics for tomorrow or Friday, where we need them to be processing it for logistics support, so that by lunchtime they are able to process and come back to say everything is okay. 5 minutes, and then we are back to the meeting with the NHLS. In that 5 minutes, Ms. Machalamba, please make sure that you are able to get them, and then let their presentation be linked and give them a link. Thank you. Okay, Professor Phahlele, good morning, and thank you very much for joining us in this meeting as a chair of the NHLS board, together with other board members who might have joined you. Welcome to you and welcome to Professor Mlisana too, the CEO of NHLS. We are meeting as a portfolio committee to listen to your presentation that talks to your annual performance plan together with your strategic issues and budgets that you really want to share with us. We would request that you introduce whoever you are with and then present not more than 45 minutes. We will then find time as portfolio committee members to interact with your presentation, which we have received, and then you'll come back to clarify us on some of the points that honorable members are going to raise with you. Your time now starts, Dr. Professor Phahlele, with your team. Thank you very much.
So thank you very much, Chair, for hosting us and for your invitation to this committee meeting. I would like to extend my greetings to all honorable members. I hope I'm audible, and also to the representatives of the National Department of Health. So yes, we highly appreciate this opportunity to present our 5-year strategic plan as well as the APP, including the budget. And I'm delighted to say that I am not alone. I do have a team, a significant number of board members. So I will just quickly run through the names because we want to save time. I won't ask them to introduce themselves individually. So I do see the name of Prof. Keith Housem, who is the Deputy Chairperson of the board. And I also have, I hope is there, Mr. Jonathan Mallet, who is the Chairperson of the HRC, Human Resource Committee, and then the Chair of ARC, Mr. Nkoko, then the Chair of Research and Innovation Committee, Professor Dibani Mashamba Thompson. I also have additional board members, Mr. Nick Buke. I also have Dr. Nelizani Ramalibana, Advocate Mate Fumajudina, and Dr. Mahlane Palane, as well as Dr. Siseko Martin. So these are the board members who are here. And I'm glad they joined us because they will hear firsthand the input and the guidance that we will get on the strategic plan, since is the first presentation of the strategic plan. We also have a full complement of the executive management led by Professor Koleka Mlisana. Prof. Koleka will lead the presentation. And just before that, Chairperson, allow me just to say that in preparing this 5-year strategic plan, we have taken into consideration the current economic climate. As you all know, and it's likely to persist for the next few years. So the pressure on the fiscus and the fiscal constraint obviously made us to make careful and strategic choices on what we want to do. But I want to highlight the fact that they are putting pressure on our core business, which is the diagnostic pathology service. You will know that most of our technology platforms and consumables that we use are dependent on international markets. So under the current climate, economic climate, is actually getting more and more difficult to provide service at an affordable cost. And then the other area, number of priorities and projects that we would like to address as NHLS. But once again, we had to make choices, and all of this will come out in the presentation. So with that introduction, Chairperson, allow me to invite Professor Koleka Mlisana to deliver the presentation. Over to you, Koleka.
Thank you very much, Prof. Mpashele, and good morning to all the members of the Portfolio Committee and the members of the NHLS board. And as you can see, in the NHLS boardroom, we have all the executives around the table, and I will not, waste time by us introducing ourselves. People can just introduce themselves as they respond to questions thereafter and their portfolios. Thank you, Chair. So I will go right ahead, and I'm assuming that the presentation is visible to everybody. And we are therefore looking at the NHS strategic plan for the next 5 years, 25 to 30, as well as the annual performance plan. So basically, what we really just want to highlight here is the importance of the National Health Laboratory Service as we provide essential pathology services, and this is provided to more than 85% of the South African population. And also just a reminder to the members of the committee that actually when we're looking at clinical decision-making process, more than 70% of decisions on how to manage patients clinically are really based and guided by pathology results, which highlights the importance of pathology within the medical fraternity. So what we really are looking at for the next 5 years is to ensure that we enhance organizational efficiency and quality within the organization. And we therefore are looking at implementing these performance management systems that will optimize workflows, that will adopt the best practices, and this must be underpinned by a robust governance as well as a sound financial management. So when we look at our mandate, this is the legislative framework that we operate within, and you will, we're just highlighting all the appropriate acts that we operate within, and I won't bore you going through this, and this is also a continuation of that. But when we really just look at our strategic focus as an entity, so our mandate, as is known, we've got 3 mandates. The first one being providing diagnostic and pathology services to all public health facilities in the country. Secondly, supporting teaching and training of pathology-related disciplines as well as research within the framework. And then if you look at our vision, we have actually concretized our vision and shortened it, and what we are looking at for the next 5 years is that we become a center of excellence for innovative laboratory and clinical medicine. And the vision obviously is ensuring that we provide quality and yet affordable health care, whilst we value our employees, the patients that we serve, as well as the communities that they come from, through innovation and collaborative work. And we have shortened our values to 5, specifically centering around employees, service excellence, transformation, innovation, and integrity. So when we look at some of the factors that are likely to impact our entity, this is what we have put together in our strategy, that obviously looking at the current water shortages in the country and interruptions in the supply of electricity. So there are certain environmental factors that are likely to impact, and therefore as we were designing the strategy, we needed to see how we are going to then mitigate against this. political factors, legal. Now we deal with patients' information, and we need to ensure that whatever we do works within that legal framework of the POPI Act. If we look at technology, because this is what we work with, so is our technology platform aligned, and are they, the cutting edge? What are some of the processes that we can utilize in technology to advance how we provide our services? And so these are the factors that we have looked at, including the current, financial challenges that the chair has already highlighted. So, this just summarizes our, SWOT analysis. What are some of our strengths, weaknesses, opportunities, and threats? And I think, for me, just highlighting the strengths, the fact that we are a national entity and therefore have got a national footprint, but also what's quite important is the existence of this national central data warehouse of all data or pathology data from the public sector. It really makes NHLS quite a strong entity. And then challenges that we have is infrastructure. And when I talk about infrastructure, whether it's the laboratories that we're operating from or the technologies that we operate as the laboratories, because all our tests really are operated from these technologies, and you find that sometimes some of these instruments are quite old and therefore they need to be changed. We have seen challenges with infrastructure even around our IT resources as well. Then some of the opportunities that we have, would be issues like now we need to ensure that all the labs are accredited, and that's what we're working towards. We want to ensure that, how do we enhance revenue, other revenue streams to support the financial environment that we're operating in, and also, moving with technology, how do we ensure that, we develop a business intelligence unit that's going to allow, allow us to make data-driven decisions. And then obviously will always be threats. We were hit by cyber attack last year, and how do we then ensure that we have got a resilient, IT infrastructure going forward? This then just gives a summary of the organogram of the entity. We have our, chair of the board and the board members. We've got the company secretary. In fact, what I want to highlight as well is that if we're looking at the executive structure, we have just managed to fill all the vacancies. So now we've got a full complement. In fact, 3 of these just started, in the month of April. And so it really gives us great pleasure to have a full, executive complement, because as we initiate the 5-year strategy, it means we're initiating with everybody on board. So in the next 5 years, this slide just summarizes the key areas that we want to focus on. I've already mentioned the IT infrastructure. We know we've always had a challenge, in our supply chain management unit, and how do we then improve and strengthen this and ensure that we catch up with whatever, a backlog that we might have? How do we ensure as an entity that we are ready for NHI? Because we're training and, all laboratory personnel, how do we strengthen the teaching and training and enhance research? And then what's quite important for us as well is ensuring that we digitize all our business processes. I have already highlighted some of the other points that are in that slide. So what we have done, when we look at the strategic focus, we really have categorized it into 5 focal points. The first point is a patient-centered approach to service delivery. How do we ensure that as we provide pathology services, these ensure that there are quick turnaround times? We use the most up-to-date technology, and what we are therefore going to be looking at, what are some of the tests, diagnostics that we can decentralize and bring them closer to the patient as is possible. And one of these, really we're looking at point of care testing. Where should we be putting point of care tests? How do we decentralize this? For example, we're looking at, the larger primary healthcare facilities, the ICUs, the emergency units in the big hospitals, so as to improve diagnostics as well as turnaround times. And then we also want to look at what are some of the tests that would need to be centralized. Things like, if you're looking at TB testing for especially TB culture, because of the issues around safety, how do we centralize that and ensure that then our TB culture labs are actually up to the standard insofar as safety is concerned. So that's what we want to look at. And once we talk about centralization, then we need to ensure that we improve the logistics and specimen checking systems. So that's the first thing that we want to look at in the next 5 years. Secondly, what about our employees? How do we ensure that we've got a fit for purpose as well as a future focused organization that has got competitive, and adequately trained staff members so that we can be competitive to the private sector pathology labs. So this, we're going to be looking at how to increase the training of pathologists, how do we stop or bridge the silos that are there? Because if we look at technology now, technology is beginning to integrate, in between disciplines, and we need to ensure we do the same. Staff retention strategies, clear career progression, as well as capacity building programs for all categories of staff. Then the third one is digitizing, because this is where the technologies are moving towards, where we want to look at all business processes and up to a point where we can become a paperless organization and use of intelligence, business intelligence for data decision-making, driven decision-making processes. Now, we want to really be leaders in pathology and therefore even with technologies. What about digital pathology? How do we introduce artificial intelligence in pathology? Next generation sequencing now is the the way to go insofar as diagnostics, as we move even towards individual medicine that we term personalized medicine. And I've already mentioned point of care tests and automation in the laboratories. And also in the current environment of tight budgets, can we explore revenue generative streams so as to increase our income? So when we look at some of the risks that we're facing as an entity, and you will notice that we have moderate risks, we have got high, and we've got extreme in the next slide. So what becomes important, as I've already mentioned, we see a challenge within procurement. How do we ensure that we minimize irregular expenditure? How do we improve on the provincial debt collection? I'm just highlighting the high ones for now. And how do we curb this rising cost of employee compensation and the skills, especially pathologists, skills shortage that we have? So these are the risks that we have identified, and there's always going to be the aging infrastructure and equipment that I have already highlighted. Now, on this slide, it highlights some of the extreme risks that we have identified. I've mentioned the issue of the cyber attack. We know that this continues to increase, and the fact that we have been attacked, it does not mean it's never going to happen again. And so we need to make sure that we put in measures in place to reduce that risk. And should it happen, we should have effective mechanisms of business continuity and how we ensure that we're able to operate during disaster. So when we look, Chair, at some of the looking at the impacts and the outcomes. So if we look at, the main impact that we want to achieve is to ensure that we get better clinical outcomes for the patients that we serve. And therefore, the outcomes that we're looking at, how do we create an efficient and an effective organization? How do we provide high quality services? And how do we ensure that we build a financially stable organization and ensuring good governance across all aspects of the organization? So if we look at the first outcome, how do we get to an efficient and effective organization? We're looking at improving turnaround times, highly skilled, competent force, and ensuring, smooth and improved SCM systems. The clinical laboratory interface must be improved, which would include, the sample collection, digitization of processes. How do we improve our stakeholder engagements and ensure resilient IT systems? For high quality services, we want to look at quality assurance and total quality management systems, and this is where accreditation of labs will come in. This is where proficiency testing comes in to ensure quality in the work that we do. This also, we want to make sure that we are on the cutting edge, insofar as health research is concerned, ensuring that we support all our researchers. And obviously, when we look at the surveillance units like the NICD and NIOH, how do we ensure a robust and an efficient surveillance system and outbreak responses for the country? So we've already highlighted the critical, and the importance of establishing a financially stable organization. And so how do we then improve the liquidity position of the NHLS? And then good governance. I mean, it is now, common knowledge that we had poor outcomes for the last financial year, where we had a qualified audit. And so the question now is, how do we then change that around and improve our processes? And we're actually aiming to ensure that by the end of this cycle, we are onto the clean audits, for the last 2 years of the 5 years. How do we ensure a corruption-free organization? I know we've had challenges, insofar as this area is concerned, and a lot has been done to clean this up, and we want to make sure that we maintain such, and obviously strengthen compliance with regulatory and legal requirements. So for the budget, Chair, I'm going to hand over to our CFO, and she will take us quickly through the budget. But just to highlight that, unfortunately, over these last financial years, we really have received less than what we had requested, as well as actually what is an inflationary tariff increase. And this has obviously, affected the entity negatively. But I'll hand over to Ms. Maegiso to take us through quickly.
Thanks, Martha. Morning to the members of the Portfolio Committee and the board members, and our colleagues from National Department of Health. So this table is just showing what Prof. Nisana has alluded to in respect of the amount that we received, or rather the percentage that we requested as NHLS vis-a-vis what we then were granted. So the problem started in 21-22, but it wasn't as significant, and then we were fortunate that in 22-23 we received what we asked for. 23-24 was a reduction where we asked for 4.7 but only got granted 2%. And then 24-25 was then a year where we saw something that we had not seen as an entity before, where we requested 4.8, which was linked to the projected CPI. And then, unfortunately, we were given indication that NHLS would actually get 1%, but that actually never then materialized. So it basically means that for the financial year that just concluded, we were charging 23-24 pricing in relation to the testing. And the members can then appreciate what that impact would be from a financial perspective in terms of our revenue generation. And you'll later then see how that then impacts what we then anticipate to be the outcome in terms of our finances. So one of the biggest issues that we have as an entity is around the provincial debt, and what we've seen year on year is that this amount has been growing. So what we did here is that we did a comparison where we compared March 2025 versus March 2024, and we've then got an increase of 1.4 billion rand year on year. The biggest province that does owe a lot of money, but mainly attributed to an historic amount, is KZN. And then you'll see that there's a significant amount that's coming through from Gauteng, and then Eastern Cape also owes a significant portion in relation to that, and then it's followed by the rest of the entities. So as an entity, we are concerned around the fact that we are starting to see a reduction if we compare year on year in terms of what is serviced towards the debt, and then this translates into an increase in terms of our debtors book. So the current status in terms of the provincial debt, so as NHLS, I think Prof has spoken to the fact that we are looking at other streams of diversifying our revenue, because currently 95% of our billing is coming from the provincial debt. We have started entering into discussions with provinces to try and encourage them to keep up to date the payments for the current amount so that we don't see our debt grow year on year. And then we are actually considering payment arrangements for the historic debt. We are aware that the provinces are have struggles in terms of the cut in their budgets. And we obviously have then seen that translate into the amount where the amount that is serviced is then starting to increase year on year. We've entered into debt negotiations, and the provinces that we've managed to have meetings with is KZN, Northern Cape and the Eastern Cape, and we're currently trying to set up discussions with the rest of the provinces when we're starting to see problems in terms of that. So we are then concerned, obviously, with what the impact of the debt is going to be on our financial sustainability. And as a result of NHLS, we're carefully managing our expenses and also making sure that we manage our cash flow, through the strategies of making sure that we pay when payments are due, and also just encourage provinces to pay us as quickly as possible. We also are concerned about the market conditions around global tensions and the funding risks, because we do have certain elements within the NHLS that are funded through the grants that is an indication that there may be problems, and we are worried around what the impact of that will be. That is also then further worsened by the fact that as NHLS, we've seen a reduction in terms of the amount that we receive as the NDOH grant, and you'll see that change in slides that are coming through. So in terms of the retention of the surplus, so we submitted a request to retain our surplus, and we were granted permission to retain our surplus, which came out as a computation of the just under 8 billion rand, and that amount is driven primarily by the provincial debt, which I must indicate is risky, but the bigger component is lying in a bank balance that sits in our bank balance. But in terms of why we need that surplus, the first one is just to make sure that we are financially stable. So Prof spoke to the fact that we need to make sure that we are liquid or we maintain our liquidity as an entity. So in order for us to maintain our liquidity, we need 3.6 billion rand. So we're able to pay our salaries and also make sure that our creditors are paid on time. And then we have seen the effects that the cyber attack has had, that we had at the 22nd of June, 2024, which did have a disruption in terms of the NHLS service delivery. And in fact, when we look at our numbers for the current financial year, or rather the March 2025 financial year, we actually had a month where over the period where we've lost 8 billion rand in terms of our revenue. So this will then obviously then translate into an impact in terms of our finances. And then in terms of investments that we know we need to make, we obviously need to make investments around the security upgrade, linked to the fact that we found ourselves to be somewhat a little bit vulnerable when it came to the cyber attack. But we also need to make sure that as an entity, we invest in IT, but also we need to also put a capital investment around our infrastructure, which is buildings, and also around the equipment that we need in order to make sure that our service offering is satisfactory and meets the needs of the patients. So we obviously are concerned around the impact of what the escalating debt amounts to, because if the provinces are not adequately servicing amount, that will then have a consequence where our bank balance will then start to go down. So we are basically also needing the surplus for that particular aspect. And I've spoken to the fact that the provinces are impacted by the budget cuts, and we've seen that translate into the manner in which they're able to pay the NHLS. And again, the declining conditional grants has also caused strain, because as NHLS, it means we now need to cross-subsidize the entities which receive the NDOH grants. The other challenge that we have as NHLS is the FCL and the backlog challenges. So FCL came onto the NHLS from the 1st of April 2022, and unfortunately, the NDOH grant that we received is nowhere near enough in terms of making sure that the issues around the backlog are addressed. So as NHLS, we have committed to make sure that there's adequate funding around there so we can then address the issues around the backlog. And then Prof has spoken around the investment that we need to make in relation to water and energy. And then we also need to make sure that we have adequate support around new medical schools. So this graph is just then showing what I was indicating around the fact that we've then seen a reduction in terms of the NDOH. So the first year that we saw a significant reduction was in 2021, 2022. And then the year that FCL came into the NHLS was 22-23. That's why you then see the amount going up. So that was attributing to the increase. And then we saw a further reduction in 23-24 and a further reduction for 24-25. But according to the indication, we will then start to see an increase. But unfortunately, because we start off with a lower baseline, it then has an impact in terms of the finances of the NHLS. And then this is just a breakdown by entity on a graphical format. And we did include a table that then shows the amounts in terms of how the amounts were going down. As you can see, for NICD in 22-23, we had 282.4 million rand, which went down to 250.5, and then significantly went down to just 198 million in 24-25, and then the same can be seen in relation to the other years. So Chair, my last slide, before I then hand over back to the boss lady, is then in relation to our budget. So in terms of our budget, as I indicated, because we have seen that there has been a reduction in terms of the tariff that we've received, it then has translated that we're seeing the growth of our income, unfortunately, not aligned to the growth of our expenses. And expenses that I must mention that actually at NHLS we are managing. So we've put in on a tentative basis for our budget that we'll get a 2% increase when it comes to our test revenue, which is the 13 billion rand, which is basically the biggest component in terms of our total income. And then our transfers is based on the amount that we'll be obviously receiving from NDOH. And then the other component that's quite big that we get as NHLS is the interest received, which is driven by our bank balance. And that's projected on what we anticipate to be in our bank balance, and also with the anticipation that it may go down. The other item that's a significant contributor in terms of our other income is actually coming from grants, and we are concerned around how that number will materialize in light of all the fact of all the things that are translating in terms of US grant and all of that. So that amount may actually end up being lower than anticipated, but at the time when we had the budget submitted, we didn't have the market variables that had taken place subsequently when President Trump basically made different pronouncements. So in terms of our expenses, Chair, our biggest expense is our compensation of compensation for our employees, which we did put at a significantly low percentage, which is linked to this projected CPI. But most of the time what we found is that though we drive a very hard bargain as the NHLS, we still sometimes go outside that when it comes to salary negotiations. Then the second item that is a big driver is in our direct materials, which is basically the cost that we pay in terms of the consumables and reagents that we purchase from our suppliers. So that item is driven primarily by Forex economic variables as well, because most of our suppliers actually import the items that we buy as NHLS, but we do negotiate very hard bargains around price increases. Even when we have our tender processes, we will negotiate for suppliers to try and reconsider a further discount, even if they were the lowest qualifying bidder. And then the next item that follows our expenses is our provision for bad debts, which is an accounting adjustment, Chair. So it's not a cash entry, but however, it does impact our expenses because we are starting to see that our debtors book is growing. And then the last item, which is also intertwined to the ones for direct materials, is our goods and services. Apologies, Chair. So I think, Chair, what we wanted to emphasize is that unfortunately, because we then see our income to be growing at a lower percentage due to the tariff that we receive, and our expenses growing at what is really linked to market conditions, we then have anticipated for March 2026 that we're going to have a 33 million rand deficit from the NHLS, and that will then start to steadily increase year on year with about 750 million in March 2027 and 1.5 million in March 2028. Thank you, Chair. That concludes my part.
Thanks. Just to continue and finish off, Chair, then if we just look at the APP and the different programs that we operate within the entity. The first one being the lab services. So this is basically the core business of the NHLS. And what we then have looked at as the outputs and some of the output indicators and the targets that we're setting for the next 5 years. I will not go into much detail, and I'm assuming that the members have had a look at the targets that we have put in place. But just quickly, what we have done with the turnaround times, because these are critical, we actually have combined all turnaround times, because each and every test that we do within the lab has a predefined turnaround time. And what we want to do this year is to rather look at all of this, and we expect to achieve a minimum of 80% of all predefined turnaround times for this following year, and I mean for 25-26, and then those are the targets for the next years, so that the members are familiar with how come we're ending up with just one figure for turnaround times. And we have highlighted the importance of rolling out point of care testing, and so we are aiming, in fact, even though we are saying we'll only get to 100% by 29-30, we are hoping that we can reach that target way before the end of the 5-year period. And the same with digital pathology. This is critical, especially against the backdrop of challenges in anatomical pathologists, in that we just don't have enough. So what we are now rolling out this year is that we're going to implement digital pathology that will allow slides to be prepared in distant labs, and then any histopathologist on the platform can view and report on those slides. For this current financial year, we're just committing to one lab, because it will be the pilot, where we want to ensure that we've got all the resources required, we've got connectivity, and then once we have done this, we will start to roll out to a lot more labs. And in fact, there will be 14 in total histopathology labs that will be utilizing digital pathology, and we're hoping to roll those to all those labs within the next 2 years. Around forensic chemistry laboratories, I know there's always a challenge around the backlog, which we have highlighted, but just to look at some of the targets that we have set, first and most importantly, we want to improve the turnaround times. Remember that we do blood alcohol, we do toxicology, and we do food samples. We test food samples as well. So insofar as blood alcohol is concerned, we actually have managed to catch up with the backlog, and we are now ensuring that the turnaround times are actually closer to what we, to the estimated and acceptable performance insofar as blood alcohol is concerned. Now, around new toxicology tests, I know that the last presentation, people wanted to know, when you're looking at the backlog, what about the new tests that are coming in? So there have been challenges around there as well, and we want to see how we can improve the turnaround times for the new work that's coming in toxicology, to ensure that at least we're getting to 40 and above 50% by the end of the cycle. The toxicology backlog, we have put measures in place, and the budget that was approved by the board, that from this financial year, there's a budget put aside both for workers, for human resources, as well as technologies, as platforms that we require to attend to just the backlog. And we have already started to get the instruments that are required. We've managed to set up extra laboratories in some of the FCL labs, and we continue to find more space for other provinces. And once then the platforms are available, then the staffing will be provided for, and we really are aiming to clear the backlog. We're saying here right until 29-30, but the team, I have told them that we really want to clear the backlog in the next 2 to 3 years. Then the percentage of perishable food samples that are tested, within 30 days of sampling. The target is 85%, and we're hoping that we will have reached 90% by the end of the cycle. And then the non-perishable foods, we're looking at 80% as well and reaching 90%. About the academic affairs, research, and quality assurance. So the first one, looking at quality assurance, ensuring that the labs that are not SANAS accredited as yet, that their audits, their annual compliance audits, they actually get to 95% and across the year. And we are aiming at ensuring that because all labs receive these proficiency testing schemes, and they've got to perform to a minimum of 80%, and so we want 98% of our labs to reach that target. And we have actually, and we think we are confident enough that we will be able to reach this target. As far as the labs that are accredited, at the moment we have got a total of 215 labs. This is not counting the individual labs within the academic units, because then we would have a lot more laboratories. But we're now just looking at the labs that we want accredited. We're currently sitting at around 175, and we want to have 185 labs, so that by the end of within the next 3 years, all the laboratories that we have are accredited, and this also is in preparation for the rolling out of NHI. And the same with certification for ISO 9001. We want all of our 8 areas to be accredited. So about research, you will notice that as far as published articles, publications, we are aiming at 700 publications. And insofar as the training of the workforce, the number of pathology registrars, the number of intern medical scientists that we are training, as well as the pass rates, we have now included on our APP. About NICD, we then want to look at a robust and efficient surveillance system and outbreak responses. And these are some of the output indicators and the targets that we have set for the years, as well as the antimicrobial resistance surveillance reporting and the publications that come from the NICD. And this talks to training of the epidemiologists and what the numbers are looking like for the next 5 years. When we look at the Institute for Occupational Health, looking at, because they do testing, laboratory tests as well, we are focusing on the predefined turnaround times for these laboratory tests, ensuring that 90% of the tests that we do are within that predefined turnaround time. And insofar as this assessment, safety assessments that need to be completed, and these are the numbers that we have put down as our targets, and the reports that get produced, and maintenance of accreditation. Now, when we look at the administration programs, starting with finance, we have included, this is what we used to have, ensuring that the ratio of current assets to current liabilities, and these are the these are the targets that have been put, creditors days, debtors days, the CFO has already talked about that. But what we now have looked at as well is the tenders. How long we're taking, to complete our tender award processes. And we're looking at tenders that are below 10 million versus those that are above 10 million, because we want to ensure that we improve the SCM division of the NHLS. And these are the targets that we have set for the next 5 years. And also, because of the same challenges in supply chain management systems, we want to automate our systems, and so we have included this on our APP, and these are the expected performance that we were looking at. We want to run a pilot of automation and then implement and track that and the improvement with the application of the automation system, see whether we're improving or not. And the same here for the infrastructure, infrastructure plan. We have talked about the challenges in our infrastructure. So we want to ensure that there's a plan that's available and we implement this plan in the next 5 years. Same with energy and water supplies. We also want to look at, if we look at then the compliance and regulatory and legal requirements, how do we move from the qualified audit opinion to a clean audit? And these are the targets we have set. And how also do we ensure that we reduce the irregular, expenditure over the years? Then this one, Chair, is looking at IT, and we definitely need to develop and implement an ICT strategy, and we will be monitoring that over the next years. We want to implement, like I mentioned before, a specimen tracking system to improve our turnaround times and monitoring of the work that we do, and we have therefore included this year, and we've already talked about digitization of all the business processes. Insofar as HR is concerned, looking at achieving this high skilled and competent workforce, how many employees are trained as the approved work skills plan, number of medical interns, medical laboratory scientists, and we've already talked about number of registrars, and also a performance-driven workforce. How much are we doing insofar as the performance contracts are concerned, whether in contracting or in reviewing and assessment at the end of each financial year? And I think this is almost my last slide, where we want to look at communications, and these are some of the targets that we have set for communications to ensure that we improve how we communicate with our stakeholders. Thank you very much, Chair, and I will stop here.
Thank you very much, Professor Mphahlele. I hope you are biting and able to chew the big bites that you are taking, and we hope we will give you all the success. All the support, and you do that. Honorable members, let me just check now. I need to just so I get all my members ready to ask questions. And now the question is coming up. All right, just mute your gadgets for now. The NHLS boardroom. Honorable Michelle Clark, you'll be number 1, followed by Honorable Van Staden, number 2. I also realize Honorable Mchadu, and then the third one will be Honorable Dr. Leroux. Any other hand so far? Those are the 4. Honorable Clark, number 1. Honorable Van Staden, number 2. Honorable Mchadu, number 3. Honorable Dr. Leroux, we are number 4. Honorable Simne, number 5. Honorable Peko, number 6. Am I missing anyone? Okay. I hope I'm not missing anyone now.
And Dr. Litlape.
Honorable Dr. number 7, Dr. Litlape, right. Okay. Honorable members, in that order, please. Thank you. Start, Honorable Clark.
Thank you, Chairperson. Just the following questions in terms of the presentation. Thank you very much for the presentation. Regarding the aim of centralizing and decentralizing of service delivery, what aspects need to be centralized and decentralized specifically? What support is needed from the department to address the extreme risks? Given that load shedding was a daily reality for so long, why are there no contingency plans for the electricity-dependent critical systems? Please explain the inability to operate during a disaster. What is being done to address the IT risk, especially given the cyber attack, when we were assured that this was addressed, yet it shows up as an extreme risk? Why are the laboratories failing to obtain SANAS accreditation? How many labs have not got this accreditation? What is being done to recoup outstanding monies from the provinces? Some of the debt is going back to 2017. When you talk about collaboration with the provinces on this, what does this exactly mean? And what is the current backlog in toxicology cases, and how far does this date back to? Thank you, Chairperson.
Okay, Honorable Van Staden, thank you.
Thank you, Chairperson. I also have a concern about the outstanding debt from provinces to the NHLS. I just want to know what measures the NHLS is putting in place to eradicate that problem. And just two other questions. I just want to know from this entity what will consequences be for the NHLS now that the President of the United States has stopped the PEPFAR funding, and your constituency plans, what are your constituency plans in place to recover from this funding that was stopped? And what total amount did the NHLS receive annually from PEPFAR? I know there will be huge consequences now that this funding has been stopped, but if you can just elaborate a bit more about that to tell us what is going to happen now that this funding has been stopped, but what you also would do to recover from this. That's all from me. Thank you, Chairperson.
Thank you, sir. Honorable Mchadu.
Thank you, Honorable Chair. I've got just a few questions. I just want to welcome the presentation. My first question, I just want to know what is your plan to turn around? What is the plan to turn around time for various specimen result? And do you have any improvement plan? Because if you have a plan as a department, it can assist doctors to manage patient. And then another thing that I want to ask, why microbiology result takes too long? The other one, there's a problem with blood culture result. Do you have something on pipeline that can report, that you can report in this committee about a blood culture result? And another question, while I was doing my oversight, I received a lot of complaints in clinics about courier services from clinics that they're taking too long to collect various specimens. Can you tell this committee whether did you receive those complaints, or is your first time to receive this complaint from us as a committee? And another thing I just want to ask, did you resolve the issue of staffing and staffing norms? What is their vacancy rates? If you can inform this committee. And another thing, another question that I think it would be the last question about the NHLS system. I think in 2024, the system crashed. What precautions have you taken to prevent the same incident from happening? I thank you, Honorable Chair.
Thank you, sir. Honorable Dr. Leroux.
Thank you, Chair, and thank you very much to the team from NHLS for their presentation. There were two questions. One's just a practical question around on-the-ground staff attitudes, and I think that I don't speak from experience because the lab that I used to deal with at Situlele Hospital, the team was excellent, and the long-term technician there was fantastic, and they were incredibly helpful and incredibly hardworking, and did an amazing job under difficult circumstances. But I certainly have been in other labs where it really is challenging as a clinician to get tests, and the attitudes of staff are sometimes quite difficult and unhelpful. And so I just wanted to get a sense of, as part of this performance plan, are there things that have been put in place to ensure that staff, especially at the lab level, are being held accountable when they are behaving badly or being unresponsible or delaying results that should be coming out more quickly? So is there a good complaint system? How does it work? And what are there any indicators that are that you have put in place to measure that and to evaluate that on a regular basis? The second question is more on the budget specifically, and like my colleagues before, I am concerned about the debt that is and the bad debt and the provision for bad debt. And I just wanted to understand on page 32 of the presentation, looking at the budget 2025 to 2026, I see there the March 24 audited actual provision for bad debt is 1.8 billion rands, and the next year is 1.2, and then going up to 1.4, 1.4, and 1.425. Sorry, 1.6 and 1.8. So I just want to get a sense. Every year we see that bad debt provision going up. Is that on a yearly basis? I mean, the question for me is, does that accumulate further, or is that for the 2025 year? There is expected to be 1.25 billion rands of debt, and the next year, for that specific year, there's going to be 1.6 billion rands of debt. And does that sort of cumulatively grow, or is the increase part of the cumulative growth? Because there does seem to be, from March 2024 to March 2025, a decrease then. So I try to understand that, and I think that, I mean, obviously it is concerning that you're budgeting for nearly 1.5 billion deficit at the end of 2028, and so and it seems like a significant part of that is due to non-payment of different departments of health, and that just doesn't seem to be an acceptable way to do things. And I think that from the Department of Health we need to understand why that's happening, but I would like to just understand your challenges with that and what you think the solution to that bad debt is, and where how can that be mitigated, because that is a significant risk for you going forward. Thank you.
Okay. Honorable Sine.
Thank you, Chairperson. Covered in terms of the debts from provinces, and also in terms of the measures in place to avoid the cyber attack again. But I just want to know, how will NHLS ensure improved turnaround times for diagnostics and also for lab results? Because in our constituencies, we always receive these complaints in terms of the delay of the lab results. Thanks, Chair.
Thank you. Honorable Teko.
Thank you. Thank you very much, Chair. Good day, and also good day to the team of NHLS that is here with us today. Chair, I am worried also about the 9.8 whatever billions that they are owed by provinces. But what I wanted to check is if their billing system is talking to the challenge that they are having. Also, as an advice that they must also make a case to Treasury to state that they are owed by those provinces, because it looks as if this is a historical debt now. With the withdrawal of the other funding and also their challenge that they are owed by these provinces will lead to a crisis. So they must be able to make their case also to Treasury so as to recover, Chair. Also on the issue of the turnaround time, I am also appreciating the fact that, Chair, they have set themselves a target, but in order to deal with the backlog that is there, the backlog that we always reported about when we do oversights, I think they must report on overperformance. If the target is measurable to them, they must overperform so that they report something differently come the next years. On the issue of samples and also laboratory services, I wanted to check if they are satisfied with the collection and delivery of samples. Is there any information that they can share with us, or are they satisfied in the manner in which the service is conducted? I have no specific case, Chair, but I just need to probe if there is any information that they want to share with the committee. I just wanted to highlight on those things, Chair, but just as an advice to them on their audit history. You see, the most entities of the Department of Health are doing very well. It's only now that we are getting them with a different story. It means they must take themselves out of that bracket. Thank you very much, Chair.
Thank you, ma'am. Honorable Dr. Litlape, the last one.
Thank you, Chair. Just in line with the question about the debts from the provinces, is there anything that can be done systemically to address that? And what I'm asking is about the monies for lab services going to provinces as conditional grants, so they are ring-fenced for payments to yourselves, or even being able to check the provinces that are not paying, how much they owe, projection of what their future liabilities are going to be for the following year, and that money being retained by Department of Health and not being transferred, so that you have paid your bad debt. And there's also provisions that are held in the Department of Health for you to be paid for services rendered by that province, because those services, those provinces have clearly proved not to be capable of managing their own affairs. The next question is about the dream of being paperless, just what the backup would be. Because my concern is that when you go paperless without second, third level redundancy of recovery in case of sabotage or something going wrong in your system, how would we deal with that? And there's been lots of comments about waiting for NHI, readiness for NHI. Can you unpack that? What does it mean? Does it mean, are we fit for purpose now? Are we talking about plugging into NHI? Or there are certain things that you may explain to us that you think NHI will deliver? Would there be direct payments from NHI? Do you know something about, because maybe there's a solution there that some of us might not be aware of that would alleviate your challenges in terms of payment. Now, the services that we provide to forensics, could they be an extra source of income? How does it work? What is the billing? When you're talking about alternative funding streams, what are you really talking about? Could there be scope to provide services to private patients and to patients on medical aid, for example? If there's a common basic package, could you then compete with the private sector in terms of providing services for that? On the issue of point of care, would that be owned by NHLS, or would there be a system where you allow the institutions to improve? For example, you used to send blood for HB, you have an HB meter, it's owned by the hospital. Can there be point of care machines that are part of the equipment of an institution so that they do that? I mean, when we worked in our earlier years, we used to do our own sodiums and potassiums in the ICU at Bara. Could the point of care be managed along those issues? Because it will lessen the burden on you, and if it becomes their asset, they must maintain it, and you can give them a maintenance program. Lastly, digital pathology, which is intriguing and is going into the future. How are you planning to incorporate augmented intelligence into your system? Because it is known that, particularly on reporting, where it's pattern recognition, the machines outperform human beings, whether they are specialists or not. What are the plans to incorporate AI into your teachings, your training, and your work, so that it can then help in terms of augmenting what the personnel can do? Thank you, Chair. And just remember, I was asking, are you fit for purpose now, or are you waiting for NHI to be better? Thank you, Chair.
Yeah, no, thank you very much, Dr. Letape. My three additional questions, Professor Mphahlele, Professor Mlisan, just note that the trend of questions from honorable members are in keeping with what also I'm going to start with, the issues of the provinces. And the Honorable Dr. Leroux put it very clearly. Where I would want to also to add on is to say, if in 2023, we had a bad debt of a million rand, why should that debt increase again unless post that provinces are continuously paying you less than what they're supposed to pay you? Because you should be able to say, let me ring fence this 1 million rand owed to us. And going forward, none of the people are going to go back and slide on that again. So we will then have to discuss about this 1 million debt owed. But everybody now going forward is paying us well, and they are actually able to deal with the current debt. So that you don't get the 1 million getting bigger and bigger every year. What is a reason for that not to be still standing at 1 million and only be dealing with it in a particular discussion? Related to that, you are raising that you propose to the department that you would like to have an increase in tariffs. And there's not been a significant support in the tariff percentage that you raised. Now, I find that a bit of a challenge because you are discussing with the department that we are behind in terms of receiving all our payments from provinces. Help us, therefore, to look into our current tariff that we are raising with you so that you can be able to do that. So it does bring an anomaly that we are not receiving everything that is due to you, but when you raise the issues of a tariff increase, we are only getting a 1%. Do you really have discussions that talk to that with the department in that regard? The last part from my side, in the past, they used to indicate to us that it was Western Cape that was doing fairly well in terms of not really doing repeat blood tests that were unnecessary. Like FBC, you can't do it daily unless you are probably in the ICU and you are looking for something else. But routinely in the wards, if interns are sending full blood count, UNE every day, the Western Cape was very strong in being able to curtail that. And you, as a service provider, were like providing a service that in the food industry, you call it, you are super selling. You are happy to get someone who's coming in to buy this item, but if they buy it every day and they buy it higher and they buy more, you then give them a discount, or you don't even, but you're just happy to super sell. Are you able to now tell, because that in the past was used to be a job of consultants, making sure interns are not really asking for unnecessary blood tests every day. Have you been able to notice a decrease in that from other provinces? Or is still one province that is strictly adhering to that part? If so, great, good enough. If not, what are the plans that we do have to put in place to make sure we improve on that part. Thank you very much, Professor Mphahlele, Professor Mlisana, and your team.
Okay, no, thank you very much, Chairperson and honorable members, for insightful questions. So we will take answer the questions. I think most of the questions will be answered by Prof. Mlisana and the team, but I don't want to give the impression that the board is not concerned, especially about the provincial debts or the so-called historical debts. So I would like to have a bite on that before I pass this to Prof. Mlisana, just to say that we are doing our utmost best to negotiate with the provinces. I hope we were at a stage where we can actually give the progress of where we are, but we don't want to really give half-baked story. But the progress is quite advanced. We engaging a number of provinces, I think 3 provinces at this stage, and I must say that we believe that before the end of the current financial year, the year that started the 1st of April, I'm sure we will be able to reach amicable solution with the provincial debts for 2 or 3 provinces at least. But we're going to engage all the provinces. I will leave this to Prof. Mlisana to elaborate, but I just want to say that from the board, we are as concerned as everyone else. And then the other area that I want to touch on is the question that is coming from you, Chairperson, about the percentage increase. Yes, we did not give the percentage increase for this presentation, but it's not just the terrain of the National Department of Health. We know that this involves the provinces as well, because it's the National Department of Health, it's also the provincial departments of health, but most importantly, it is also the National Treasury. So all of these parties have to have a say in terms of what is affordable, and it's always, you know, a compromise of what National Health Laboratory Service is asking. And it was not bad if you look at our track record. I think in the last 2-3 years, and especially because of the kick-in of fiscal constraints, then it became an issue. And the provinces do have reasons that they advance, and the National Treasury as well does have, you know, a couple of reasons that they do advance. But overall, I just want to assure the committee that it's really about give and take. And we are aware that obviously if we get small percentages, they do have a negative impact in terms of the revenue that we collect. But we are constantly negotiating. So with this, I would like to invite Prof. Mlisana just to elaborate on some of the technical questions that were asked. Over to you.
Thanks, Prof. Thank you very much, Chair. And we also appreciate the questions that are coming from the members of the committee. So we will just each and every executive will respond to questions relating to their sections. I'm going to try and just touch on a few of the questions. The first one that came from Honorable Clark around what do we mean by centralization versus decentralization. As I explained in my presentation, there are obviously tests that need to be closer to the patient for efficient patient management. And some of these, we now have got technologies to do them at the bedside or near, which is what we call the point of care tests. And so we're looking at what are some of the critical point of care tests can we make available and closer to the patients. And we are rolling out point of care testing, and we have targeted initially the ICUs, we've targeted emergency, medicine areas. We are also looking at large community health centers, and the plan is that we would place these POCT instruments, and this covers also Dr. Leklape's question. Because we want to ensure that whatever data that comes from point of care testing, it's got to be integrated onto the national database. So our plan is that we would put those instruments, we are talking with the clinicians to find the best mechanisms of ensuring that whilst they might do the testing, how do we ensure that those instruments are actually linked to our lab information system. So we are looking at where possible, those instruments can be run by the clinicians, but where it is not, we are looking at exploring, making available, for example, it might be phlebotomy technicians who can come in and they might run the POCT machines in an emergency section. And then about decentralized tests, like I mentioned, typical one that, that is the first one that we need to look at is TB culture labs. Because of the safety issues, you cannot have TB culture labs across the country, but we have designated TB culture labs, and we then want to look at how do we ensure safety and ensure that we put in, for instance, what we call BSL-3 laboratories in all our TB labs, and we centralize the testing. The other area of centralization is going to be, as a microbiologist, for example, there was a question around turnaround times for microbiology. Microbiology has always been very manual, but now there are technologies that have actually automated micro. And so the next thing to look at is where can we place automated microbiology labs in the country? Because then, and when we look at automation, it can only be cost efficient with the volumes, and those would be the areas where we would look at centralization. There's a question around the load shedding and the plans for that. We have mentioned that in the next 5 years, we want to look at how do we improve our access to electricity, and there's a plan that's in place, and to set up whether we go the route of solar or what else becomes efficient for the labs. So there is a plan that we have in place already with timelines. And then the other one I thought I would take would be the question that talks, I've already talked about point of care, digital pathology. So insofar as digital pathology is concerned, yes, we are exploring as to how do we then incorporate artificial intelligence reporting, because obviously as more and more pathologists begin to report, we will be able to create AI that could assist, and obviously with a digital pathology is going to mean those images are able to be stored, and they therefore can be used for teaching as well. So you are spot on that. That's what we really want to look at. And then the issue really around the turnaround times, and I'm now going to hand over to Prof. Mayer, who is our newly appointed laboratory service executive. But just to say that we are in the process of ensuring that we have an order entry system in place which is going to track the specimens. So this system will be able to determine when the specimen was collected and what happened to it until it gets to the lab and it gets reported. So we have got 2 of those systems we're going to be rolling out. E-labs, which is going to be used in the primary healthcare facilities, and we are piloting order entry that is going to be, deployed in the hospitals. This then is going to ensure that we can monitor our turnaround times. And in addition, we definitely do want to look at how we can tighten our couriers at the moment to ensure that there is proper tracking of the couriers as they bring samples back to the lab. Then let me hand over to you, Prof. May, and then we can touch on other, service-related questions. Thank you.
Okay, thank you everyone for this chance. This position has been vacated for quite a while, so I accept that there's some inherent problems with monitoring that needs to be stepped up. As far as turnaround times are literally monitored at lab level, then goes to the business management level, to area management level, and the LIMS reports are accessible, and they are looked at, and especially in our SANAS accredited labs, should you fail, there is a process of opening a non-conformance, and these are audited, and it is addressed at site. So going forward, these reports that will now come to me, and I have to assess and immediately address issues and then go to my sections in my region. So I do acknowledge that there might be some inherited problems, but this will be addressed and has been addressed in my few days here, where I then engage with the stakeholders immediately and set plans in action to eradicate all that. So yes, so that if the turnaround time is managed and set properly, there wouldn't be any problem of getting results, getting your specimens done in a selected time, and that will also, in a large way, be addressed when finally all our labs is under SANAS, because under the SANAS regulations it's very well guided, and we have yearly audits to see where our shortcomings are. So we definitely will address that. And currently we also have internal audits, our QA department, that looks at these issues. And again, maybe I'm speaking under correction, the final outcomes of that are not looked at the national level, and maybe going forward that should be the issues. I just want to also address the issue of multiple, like full blood counts being asked on a daily basis. We have what we call the EGK, or the electronic gatekeeping system, which is supplied to us by the Department of Health. It's very granular, very detailed of what can be asked in certain areas, in certain outpatients. For instance, you can't ask certain tests, and that's fed directly into our lab systems, and it will be rejected. So this is driven from the Department of Health. We have to honor the requests that we get. So, and I think this system has been in place for many years and is working quite well, and is regularly updated as well. I think as far as complaints by physicians and doctors on a hospital level, yes, there is in most hospitals a monthly meeting with the CEO or the staff of the clinic, with the business managers, where these issues should be and will be raised, and I've been in meetings like that. So I think there is a complaint system, and again, in those should be noted, are reported in our monthly reports, should be picked up and escalated. And maybe just finishing off, seeing that I'm now standing on a national level, I'm sure dropping me an email if you do not get satisfaction in any way and form, I will assure you that I will address the issue then and there.
Thanks. I think we'll go to the CFO around all the debt, and I think actually the chair had already, highlighted our concerns, but I'll leave the other, finance-related questions to the CFO.
Thanks, Professor. So Chair, I think in respect of all the questions that have been raised around the debt, so the first one was asked by Honourable Member Clark. So in terms of what we've done as NHLS around our debt, and I probably asked by more than one member, we have actually been arranging meetings with the provinces so that we can have an in-depth discussion to understand what their intentions are around the debt. And then I know that the National Health CFO has been also heavily involved around facilitating interactions between myself and the CFOs for the provincial departments. So I've been invited to their meetings where they sit as a collective, and I have presented what is owed by the provinces, and we have managed to secure meetings to discuss payment arrangements with KZN, with Northern Cape, and then we had started discussions with the Eastern Cape as well. We had tried to also set up a discussion with Free State, but unfortunately our meetings had not yet materialized, and that the same can be said for Free State as well. So there are certain provinces for which we're not yet concerned. Example is Limpopo and the Western Cape. Their accounts are up to date. So we will have a stakeholder engagement so that obviously they can still continue to service the debt, but at this stage they're not really contributing to our problem. But the province that we've had multiple engagements, and there's even been correspondence that has gone between our principals, is KZN, and it's because we obviously need to resolve the amount that we show under 2017, 18 and prior years, which is a historic debt. And just to point out to the members that if we look at the trend for KZN, the problem actually lies in that year. After that, we actually see a pattern where they were actually adequately servicing the debt. So I wanted to just say from our side as NHLS, we actually acknowledge that. It's the resolution and a solution around the historic debts that we currently in concluding, and we've had multiple interactions because we are aware that's something that was there for quite some time. For Gauteng, we actually had a payment agreement that was in place, but at some point around COVID time, there was then issues around the servicing of the payment agreement. So that's what we need to then enter into discussion so that we can get them to, start paying towards that. So I've noted the comments as raised by Honourable Member Tembalam around the putting our case to National Treasury, and I think it's one of the things that the board has also said we need to start having discussions and setting up those discussions, but at this stage we haven't started on that. And also around ring fencing, which I think I'll ask my colleague from National Department of Health to comment on that, and the possibilities around ring fencing, the funds around laboratory testing and making sure we don't have any issues around the servicing of the debt. So I'll ask him to please assist me around that. And if I then may also respond around our billing system. So our billing system, we're not aware of any issues that would cause us, or rather to be contributing to the issues that we have. The primary thing that we've identified that has really contributed to the reduction around the servicing has been around the reduction of the budgets for the provinces, because we've seen a steady decline year on year, starting from 22-23 around the servicing of the debt. The other question, Chair, that I'd like to take is around the comment that was made on the courier services and the complaints at the clinics that was raised by Honourable Member Judge. So just to say that we actually awarded the tender for courier services to multiple service providers, but since awarding that tender, because we have been doing performance management, we've had terminations that we needed to implement. Some of them I think actually had come in at previous questions that came from yourselves around that. So we are closely monitoring that, but we are, to what Prof. Nisana had indicated, we are looking at the ways of improving around, you know, the solution that we do around our logistics as NHLS. But as NHLS, we are not aware of any fundamental issues around the service, but we note that, and together with the lab executive, we'll look into that and see how do we address the issues that have been raised around the clinics and the collection of the specimen. I think then the last question that I'd like to take is around the questions that were raised around the provision for doubtful debts. So as I indicated before, that one is an accounting adjustment, and just for the benefit of the members, it is a calculation that's based on accounting standards. And it is driven primarily by a pattern that, together with our auditors, we identify around our payment trend. The numbers that we see there in terms of 1.2 billion, 1.8 billion, 1.6 billion are actually in relation to that financial year, and what we anticipate to be the adjustment around the probability of non-collection. I hope that makes sense, but that's probably the most simplistic way that would explain it to a person that does not have a financial background. So the number does actually continue to grow year on year. So if, say, the first financial year was the one that had the 1.8 billion, so that would be the value that we have. In the following year, if we have 1.2, it means the number then goes up to 3 billion rand. So it is a value that continues to grow and can go up or downwards depending on how we see the payment trend. So the numbers we put into the budgets are really based on our best estimate at the time. So it is really a singular number, but it is built over time, and then we carry it in our balance sheet. I think that covers my section. Yeah. Okay.
Thanks, Professor. I'm going to ask the new CIO to comment on the IT-related questions, and just to warn the members that actually she's been with us for 20, no, not 20 days, for 5 days. Oh yes, she started last week, but we will add, you know, but I'll allow her to just go ahead. Just introduce yourself.
Good afternoon, everyone, and thanks for this opportunity. Dr. Sylvia Sateche, 5 days old, CIO of NHLS. I'll address the issues that were raised relating to cybersecurity or cyber attack, and maybe also going a bit into the paperless and the redundancy. Maybe just to start by saying that, you know, while no organization can guarantee absolute immunity from cyber attack, given the evolving threat landscape, we are deeply committed to making sure that we strengthen our defenses and building a robust resilient system. Maybe just to touch on what we are doing now to try and make sure that, I just said we can't guarantee absolute immunity. Should there be another attack, what are we doing in place, what are we putting in place to make sure that we are resilient and there is business continuity after, or minimal interruptions after the attack. We are implementing a multi-layered security approach, where we're looking at also maybe it's about people and also processes as well as technology. We are putting in place proactive and preventative technology controls. We are looking at our firewalls, we're looking at endpoint security, we're looking at our patch management system, asset access control, and also maybe also limiting the number of concurrent logons that we can have, learning from the cyber reports that we had. We are also putting in place your security web filtering in terms of access, making sure what sites can we access, email security, and we are putting in place data control and prevention mechanisms. In terms of policies and procedures that we're putting in place, we are also going to be reviewing our business continuity plan and our disaster recovery planning as well. We are also going to be very prudent in testing those are working, testing our incident response plans, but we're also going to be assistant or relying on our auditors to audit whether we are indeed following certain processes, including conducting some risk assessment. And this risk assessment becomes very important in knowing what are our crown jewels in ensuring resiliency in the event of an attack. I mentioned we are looking at the human factor. We've just awarded a tender to go and have a cyber awareness training, and we will be training everyone who access our system. We are looking at having a compulsory training once a month where everybody has access to our environment should be able to forgo a training and be tested, and if that is not done, there will be some consequence management, including denial of access to the system. We'll also be phishing and testing, and just testing the robustness of what is happening, and all of this will also be guided by the threat landscape. We will be on the lookout to check what is happening in the industry, and so that our training is also very directed to be responsive. I mean, our first line of defense become our people, and that's where we need to get into the training. In terms of the paperless, we have mentioned that we are going to go into a digital transformation journey, and again, it's about the people, processes. We will start by also while making sure that there's digital training and assessments to know how far we are or how safe we are when it comes to certain things. We'll also document and so that when we digitize our processes, we digitize processes that have been reviewed and documented. But maybe just to give an example of how we'll reduce and going into the paperless side of things, we have mentioned that we are going to be digitizing our SCM processes, digitizing some of our human capital management processes, and some of the systems that we have in place already, which we are looking at optimizing and maybe going into a cloud-based solution like your track care system that really gives us a unified patient information. It does assist towards us going into your paperless. Some of the projects that we mentioned, our e-games and our order entry systems, are geared towards making sure that we are paperless. And I think the CE has mentioned the investments that we're going to be doing into our IT infrastructure, just to make sure that we've got infrastructure that is very responsive and we can build on top of it. Thank you, Chair.
Thanks very much, Sylvia, for a 5-day-old. Thank you for the contribution. We'll ask the HR executive, and then we'll look at the backlog in toxicology, and then around PEPFAR funding and the number of accredited labs. Really staffing norms. Yeah.
So thanks, CEO. The issue of staffing norms, I think maybe let's take a step back. In terms of the vacancies that have been an issue in the past few years, we have allocated budgets for that in this financial year, and we have started to recruit and replace in those vacancies. The issue of staffing norms, we have put together a task team that is going to actually look at the previous exercise that was done in terms of the time studies and all that, and determine the relevance of that to date. And we're hoping that we will be able to then come up with definite norms out of this project. We just recently put together a team that is led by the CEO's office, so it's reporting to the CEO's office on the letter.
Okay, thank you, Chair. Good morning. I'm Dr. Clotilda Oliphant. I will respond to the questions that were raised around the forensic chemistry laboratories. The first question was from Honourable Member Clark, and she asked what is the size of the backlog and how far does it date? The current toxicology backlog is at 37,000 samples. These date back to, they're inherited at the time of the integration of the forensic chemistry labs with with the NHLS, and the CEO did expand on the plan or the strategy to address the backlog. All of the samples will be analyzed, and it dates back to 2006. All of the samples will be analyzed, and the forensic chemistry lab team is working closely with forensic pathology services on the analysis of these cases and also the reporting to ensure that these cases can be closed off from the side of the forensic chemistry labs. Honourable Member Letlane had a question about the services and whether the NHLS raises an income in relation to the testing. Just to report that the forensic chemistry lab receives an additional grant from the CFO included in her presentation an outline of the steady reduction in this grant that has been experienced over time. So the NHLS does not at present generate revenue in relation to the forensic chemistry testing. However, there has been an increase in or an expansion in the demand in terms of volumes and also in terms of the scope of testing, particularly for food testing in recent months. So this is something that will be explored going forward. Thank you.
Thanks, Chair. The last one would be Prof. Subscates around PEPFAR funding as well as a number of accredited labs. She also just started now in April, so I'm still trying to, or else I can just say Elise will take us through the answers. Thank you.
Thank you, CEO. Thank you, Chair. So the first question around lab accreditation was from Honourable Member Clark. She wanted to know how many laboratories are SANUS accredited. So this is one of the key strategic measures in place to ensure that the NHLS is NHI ready. And so currently our national central laboratories, of which there are 53, they are all accredited. Of the provincial tertiary laboratories, of which there are 17, they are all accredited. Of the 46 regional laboratories, 38 are accredited. And of the 140 district laboratories, 73 are accredited. Then with regards to Honourable Member Staden's question on the US stop aid, the contingency plans and the amounts. So NHLS was receiving support from 14 awards from the USA, of which 10 were, of which they were all stopped, and then 10 were rescinded and 4 were restricted. The total amount of those 14 awards was 268 million. Of the 4 that have been restricted, CDC PEPFAR is not one of them. And so that has been rescinded and we are receiving those funds. As far as the contingency plan goes, so the CDC PEPFAR funding has been restored following the court order ruling the President's actions unlawful. NHLS has been engaging with CDC. They've had several meetings and budget reviews. The 4 restricted projects, which involve staff members who currently funded involve staff members who will be currently funded by the NHLS in the grant funding period until September 2025. So NHLS, as far as the contingency plan goes, is in communication with CDC as well as the Global Fund as a future contingency plan.
Thanks. Thank you very much, Elise, for that. And just to add, we as the NHLS have also committed into identifying what are some of the key functions of the NHLS that were being funded by the US government, and we are currently planning to ensure that those get funded internally. That would be our, one of our long-term solutions. And we're also going to be engaging the Department of Health around some of the, surveillance activities that are being challenged because of the restricted funding. And we will be able to ensure that those services continue as we discuss with the department. Prof. Mphahlele, I think let me hand over to you. When I look at the list, I think we have addressed all the questions that were raised. Thank you very much.
Yeah, no, thanks, Prof. Nixana, and apologies that I had to show my camera. I don't want to abuse the opportunity that we have because I know that there are other entities presenting today. So, Chairperson, from our side, I think we answered most of the all the questions. Perhaps just to say, we have taken note of the concern raised by Dr. Carl Leroux, Honorable Dr. Carl Leroux, about staff attitude in terms of availing the results. We will take it up with NHLS staff. And the last thing would be that the question raised by Honorable Dr. Letlape in terms of what we mean by readiness of for NHI. Are we fit for purpose? Just to assure honorable member that we are fit for purpose. In fact, I was going to ask management just to give stats of the laboratory that are already accredited. And fortunately, that has been given, but there is always room for improvement. And I think that's what we mean by readiness for NHI, and the fact that our labs are all over, including peripheral areas, and we want them to perform at a level that will be able to support the NHI when this kicks in across the country. So it's not like we are not fit for purpose. We are. So with that, I would like to hand over to you, Chairperson. Thank you.
Okay. Greatly appreciated, Professor Mphahlele, that you find time with other board members to stay right through with the NHLS team led by the CEO, Professor Mlisana. Greatly appreciated, and you are able to also to assist in clarifying some of the questions that have been asked. We will continue working with you, and we also would wish all the best in improving and making sure that you achieve what you desire, a better audit outcome than what you do have. You don't have to answer this now, but when we meet with the department tomorrow, we will ask them on the progress of their making to assist provinces to help you. But they too are saying NHLS must come in and indicate when are they ready for the floor space that they use to pay towards that rental. But of course, I'm sure sitting where you are, you can't, whether there's no invoice coming through, start paying. There has to be some negotiations and discussions to finalize that process. Thank you very much. Continue with your good work, because you are the only laboratory system that we have for the country. Keep on improving. This is something that is unique that you don't find in many other countries. So we really thank you very much for the hard work that you do. Ours is to oversight, and where there are gaps, ask you to clarify us and close those gaps. And we wish you all the best as you log in now. Thank you very much. And I think those were your last comments as Dr. Mlisana was handing over to you.
Thank you very much, Chair.
Thank you, Chair.
Honorable members, we will be convening at 5:22. Thank you very much. You do take your lunch break. 5:22, let us be back. Ms. Machalamba, assist the SAHPRA team to be logged in at 5:22 and then be able to start the presentation as soon as we are back. Thank you very much. Have a good lunch, and bye-bye to the NHLS team under Professor Mphahlele.
Thank you very much, Chair.
Thank you.
Recording stopped. Recording in progress. Recording stopped.
Ms. Machalamba, so that we really
Recording in progress.
start on time, please log in the team from NHLS, sorry, from SAHPRA, and then get us ready to start. Members wrap up in the next 3 minutes. We'll start at 2 when the portfolio committee is ready to receive another report from SAHPRA. Those from SAHPRA, if they are there, please can they receive sharing rights, and then they start getting their presentation up. Thanks. Okay, honorable members, I was buying time that the presentation will be loaded by the time we start, so that we don't have those hiccups to say, can I have sharing rights? Please give me this, give me that. But anyway, we hope that is not going to happen now, because I requested the logging in at 5 to 2, so that our secretariat, together with the presenters from SAHPRA, would deal with those logistics and give them 5 minutes. It doesn't look like it has happened.
It's Helen Rees here. I see that Tumi is on the call, so I suspect she's trying to do something as we speak. But there she is.
Okay.
Apologies, Chair. Do you want me to immediately go into this? I thought you were going to introduce the matter, then I'll share my screen to present once you've done so.
I don't mind, as long as we don't get a call that I don't have sharing rights. Please send me this, that, and the other. That should have been sorted out as we start. Welcome to Professor Helen Rees. Welcome to Dr. Semente and the team from SAHPRA. We are, as a portfolio committee, are going to be having time to listen to your presentation that covers the annual performance plan, your strategic plans, and the budget. We would then actually allow you now to start. That you will have 45 minutes to make presentation, and we will engage as portfolio committee members who are logged in here. You then come back again to maybe clarify us on some of the issues that members would have raised with you. I now hand over to you, Professor Rees.
Thank you very much, Honourable Dr. Tlomo, and to the Portfolio Committee, honourable members. Thank you very much for this opportunity. We have a number of board members who've indicated that they will be joining. I'll just outline who they are. Because of time, we won't allow people to introduce themselves. So Dr. Obakeng Kauli, who is the Deputy Chairperson of the board, Professor Patrick Damana, Dr. Kani Ngobesi, Mr. Faisal Dokrat, Mr. Atani Mashao, and Ms. Mandisa Skosana. The introduction will be made and the presentation will be made by the CEO, Dr. Tumi Simete, and we will all be listening and available for questions at the end. So thank you very much for the opportunity, and to Tumi, I'll hand over to you. Thank you.
Thank you very much, Chair, and thank you to the honourable members for inviting us for this session. I will share my screen. And please confirm with me if you're able to see. I think you can.
Yes, we can.
You should be seeing one slide, or are you seeing two?
Whatever you did now, make the slide to be different. Leave them on the first button that you had pressed. We were seeing it well then. Yes, this is the right way. Thank you.
All right, thank you. Thank you very much, members, again for this opportunity. And I will be sharing the SAHPRA 2025 to 29 MTF period strategic plan, as well as the annual performance plan for the 25-26 financial year. I'll give a brief introduction of who we are, what it is that we do, just speak around our act, the operating context, then I'll go into the two items. Chair, I'm here also with the executive team, who I will introduce in one of the slides, and the CFO will present the financial elements. So just briefly to honourable members, quite important to us as a regulator is that we operate within the prescripts of the Medicine and Related Substances Act, Act 101 of 1965, which has been amended. And really within this act, it mandates us to ensure the safety, the efficacy, quality, and performance of medicines. So all products that are considered medicines, medical devices, diagnostics, radiation emitting devices, and other related products are then under the regulatory oversight of SAHPRA. Chairman's mentioned that we have started a process to overhaul the Medicines Act because it's been amended numerous times. You are aware that this is an act of 1965. So towards the end of the year, through the National Department of Health, we will be coming to the committee and table with you our revised SAHPRA bill, which we have already started working on. And really, Chair, at the core of what we do is that we must monitor, we must evaluate, we must regulate and investigate, as well as inspect health products in compliance with the prescripts of the Medicines Act. There are two acts that govern what we do. It is the Medicines Act that I've just made reference to, but with the establishment of SAHPRA, we now also have regulatory oversight for those products that emit radioactive material. And so this is catered for within the Hazardous Substances Act, Act 15 of 1973. So these are the two acts that we anchor our work on. But that said, we also make sure that whatever decisions that we made are compliant with the Constitution of the country, the National Health Act, and other relevant acts. As Prof. Rees mentioned, we've got our board members that have joined us today, and these are all of them listed, 14 of them, listed and with their pictures here. Chair, I must mention that the term of the second board of SAHPRA is coming to an end in June 2025, and we look forward to then having the new board appointed by the Minister of Health. This is the executive team, and we are here with yourselves today. And we have our board secretary, we have the HR executive, chief operations officer, myself as the CEO, our chief regulatory officer, and our CFO. So we have a full complement of the executive team with no vacancy. Before I can proceed, members, to present on the strategic plan as well as the annual performance plan, I thought I'll share some context which we find ourselves operating in quite recently. And I'll talk around the context from a regulatory perspective and then just broadly from a health sector perspective. I won't speak to it verbatim. But broadly from a regulator point of view, we are of the view that SAHPRA's role is becoming more and more better understood by stakeholders and more so the public. We're seeing a lot of reports coming to us for any adverse drug reactions, but also we're seeing a lot of reports coming through to SAHPRA on the increase that we're seeing of substandard and falsified products, an area that we have focused a lot of our efforts to ensure that we safeguard the public from these substandard and falsified products. Furthermore, Chair, I thought I'll just provide clarity that one of the contexts we constantly engage in is around the matter of cannabis. And I thought I will just clarify that SAHPRA's mandate only pertains to when cannabis and the various cannabinoids are utilized for medicinal purposes only. Everything else that is not for medicinal purposes, whether it's for food applications or whether it's the space cookies or even for industrial application, does not come within SAHPRA. So that those for industrial and agricultural applications, they would be regulated by our Department of Agriculture, and then those that are used for as food products would then need to be regulated by the National Department of Health, its Food Directorate. Another area that we constantly are looking into, especially over the last few years, is around the African traditional medicine. We have put in place a working group that is looking to work with us in the development of a regulatory framework for African traditional medicines, borrowing a lot from what the WHO has put in place. From an African context, when it comes to regulation, we constantly, as regulators, engage with the Africa CDC around any emerging public health emergencies, whether it's an epidemic or a pandemic, so that we can respond to that by ensuring that the respective countries have access to either vaccines or therapeutics that are required. Quite important at a continental perspective, Chair, is around the ratification of the African Medicine Agency Treaty. South Africa has not ratified this treaty. We have about 30 countries on the continent that have ratified the treaty, and South Africa still has not. And so we are soliciting support in this case. Globally, I think we have a very strong collaborative community of regulators and all working together quite well. In terms of the health sector, just briefly, at a national level, we are seeing increasing capacity in manufacturing of vaccines, local manufacturing of vaccines, medicines, and medical devices. Although the companies are a handful, but we certainly are seeing an increase in that. We are also working quite closely with the Department of Health to ensure that we're positioned to support the implementation of the NHI. And the third point that I'll mention really straddles across the local context, African as well as global context, with the US government stop work orders and funding that has been put on hold or stopped. This has had an impact on clinical trial studies. And with South Africa being a hub on the continent for excellent clinical trials, this is an important area that we need to ensure that we safeguard and we continue to support. So from a regulatory perspective, we are engaging with the principal investigators so that we work with them on how to then transition these studies. And as I said, this applies across the various areas that I'm speaking to. From an internal perspective, what we are seeing, and this is something that we're managing quite tightly, is that since about 2023, we're seeing a decline in the number of applications for new medicines. And it's largely around new chemical entities as well as generics. And this could signal two things. Firstly, the consolidation of the sector, which we are starting to see. You see some companies like Eli Lilly, etc., Amgen, handing over their products to some of our local companies. But also it could demonstrate that there is a deprioritization of the South African market. So again, for us as a regulator, it remains important as part of our mandate is access, that we ensure that we drive efficiency so that regulation does not become a barrier to access to health products. But I think it paints to a broader picture around the South African health sector. Areas of growth that we're expecting over the next few years is in the area of medical devices and IVDs, as well as complementary medicines as we start to register those products. We have had delays in the gazetting of the respective regulations, and this is because we do need to conduct a socioeconomic impact assessment for these regulations, but this is something that we're working on. Operationally, there's a lot of positive developments. At SAHPRA, our HR function is progressing quite well, and we have a new HR executive appointed in September of last year. And I must say, Chair, there's quite a lot of stability, even in terms of our relations with the labor union. We are also implementing digitization. It's quite a big project for SAHPRA because we do need to ensure that we do not continue to work in manual mechanisms, but rather digitize our operations. And while we digitize, we don't want to leave out an opportunity for us to integrate artificial intelligence in how we work. Considering the limited human resources we have, there are areas that we have identified wherein AI will have quite a significant impact in driving efficiency and alleviate the need for us to fill those roles with warm bodies, but rather to ensure that we build in AI tools around that and make sure that the staff that we have continue to focus on the more complex task. So the more rudimentary, mundane tasks will be done by AI into the future. In response to some of the developments at a country level that I've spoken to, we have now published our guideline on how we are to align with the BBBEE Act, and this is now under implementation. And we will also be quite soon publishing our policy on supporting local manufacturers in the health sector. So with that context, Chair, I'll just go straight then into the strategic plan. I'm not going to go through these targets word by word. We did share the presentation last week, so I will take it as read. But I just want to highlight, Chair, that what we intend to maintain over the MTF period is an unqualified audit opinion with no material findings. Last financial year was the first year that we achieved this. And this was really great strides for us. I mean, I remember when I joined in 2020, we were sitting with qualified audit opinions with about 100 or so findings. So the team led by our executive has done really well, Chair, to ensure that we build a culture of compliance with governance practices. We build a culture where we have a zero tolerance to fraud and to non-compliance to our quality management systems. And it continues to be a work in progress, but I do think that the executive team have done well in leading us in this area. And one area that we guard very jealously is our SEM area to make sure that there are no non-compliances there. The second one that I'd like to speak to is around our sustainability. This is an area that we monitor quite closely, considering how we are funded, which the CFO will speak to quite soon. I've touched on digitization. That is one of our big projects, but also linked to that is ensuring that we've got a capable workforce within the capacity that we require. I'm going to move to the next slide. In this slide, I want to just highlight a few of our targets, and these largely speak to our core function, which is the regulatory function, where we are monitoring the time that we take to arrive at regulatory decisions, whether it's in the issuance of GMP or GWP licenses, whether it's the time we take for making decisions on clinical trial studies, the time we take to arrive at registration decisions for generics and new chemical entities, but also quite important, the time we take to act when there is an adverse drug reaction that is reported. So all of these measures are quite important to ensure that we drive an efficient and effective regulatory function. So I'll go into a bit more detail in terms of what then our plan is for the 25-26 financial year. We have overall about 29 targets, and the bulk of them, about 72% of them, sit within our core business, which is the regulatory area. That is program 2 to program 5. And I'm going to speak to those. So firstly, under leadership and support, this is program 1, and this is where our leadership functions sit, as well as our administrative support in finance, HR, quality management, etc. And here, as I've indicated, we do want to ensure that with the audit that has now started for the 24-25 financial year, we maintain an unqualified audit opinion. I've highlighted we monitor our sustainability and we report on our current ratio. Within this program, 2 quite important stakeholders that we look at and we do regular surveys are our internal stakeholders, being our staff. We do surveys, and out of those surveys, we would have action plans and implementation plans that we then need to put in place to ensure that we retain a satisfied workforce. And also looking at external stakeholders, we also do a stakeholder perception survey and implement findings from there. Some of the targets within this also include training of our staff. We are a knowledge organization, so it is important that we continuously invest in the learning and development of our staff members, and so we have a target around that, but also to ensure that we maintain our staff turnover to just below 10%. This is an area that is quite important for us, particularly as we lose some of our staff members to industry that would typically pay them higher salaries than we are able to. And lastly, target number 8, it speaks to our digitization, wherein we will now be starting with phase 4 of the implementation. Program 2, we call it Health Product Authorization. So this is the program wherein applications come in, they are then screened and then filtered into the various evaluations, and then any decisions that are communicated to the applicant are through this process. So we are targeting that per annum, we will finalize about 60 new chemical entity master applications and 420 generic applications. Just to say that per annum, we receive about 300, for 24-25, we received about 364 generic applications. So this number is more than what we receive per annum, but it's because we want to ensure that we claw back the backlog. And we have been, I think, successfully able to go back and claw a little bit of the backlog, but we're a lot more intentional now about ensuring that we don't build a backlog and we go through those applications quite swiftly. Quite important for our context in South Africa is what we call type 2 variations. This is where there's a product that's been registered, but if there's a change in a manufacturing site, we then need to make sure that we update the registration to reflect that information. Another important, 2 other important targets here around the ISO certification that we want to manage. as well as achieving maturity level 3 for medicines. We currently have a maturity level 3 for vaccines. And again, as I spoke around the culture of quality management systems, these two targets speak to that culture. The third program is Inspectorate and Regulatory Compliance. So this is where our team would go out to the pharmaceutical manufacturing facilities across the world. They would inspect them, and we would then make a regulatory decision. Also, this is where the team goes out to inspect sites that are non-compliant with the Act. So recently, you may have heard of facilities in Durban that were had medicines that were not they were not licensed to make those medicines available. The conditions were poor and not compliant with our GMP conditions or GWP conditions. And so our team goes out across the country and they look at these sites that are not compliant. So here our target speaks to the time we take to arrive at a decision for issuance of these good manufacturing or distribution or warehousing practices. Also, this is the area where we process permits for import and exports of products. So again, we measure our efficiency there and our efficiency in ensuring that when there is a recall, we act on that timelessly. The fourth program is clinical and pharmaceutical evaluation. So this is a team that assesses the actual dossier to say, do these products do what they claim to do? Are these products manufactured in a quality compliant site? And are these products safe to be consumed by the public? So a lot of technical team members that we have in the area. And again, the targets, I won't speak to them in too much detail, but they're really about looking at our efficiency to say, how long do we take to arrive at a decision, and how many, in a form of a percentage, applications do we then assess within a specific time frame. We cannot only look at registration decisions, but we also have to look at, once a product is in the market, we do need to constantly monitor their safety together with the companies. And so we look at when we identify a safety signal, how quickly do we communicate that? How quickly do we finalize that it is indeed a signal that must then be communicated to the company that holds the certificate of registration? And also, lastly, in this area, we drive a lot of our public awareness campaigns. We need to communicate to the public about these safety concerns. We need to communicate to them about any findings regarding the clinical efficacy, and the safety of the products. And then the last program, medical devices and radiation control. Here, as the name says, we regulate medical devices and radiation emitting devices. Again, here we would look at our efficiency in terms of the licenses that we issue, in terms of the final product registrations that we would be implementing through the feasibility study, as well as licenses for these radioactive materials. So I'm going to pause there, Chair, and ask our CFO to take us through the MTF budget projections.
Thank you, CEO, and good afternoon. The table indicated there's our MTF budget projections focusing on 25-26 onwards. The fee income for SAHPRA is expected to increase year on year with around about 14%, and mainly due to the impact of the new fee regulation that has been gazetted on 12 February 2025. The transfer from the National Department of Health expected to increase by inflation over the MTF period. On compensation of employees, or COE, 12% year-on-year increase is expected or budgeted for, mainly for a cost of living adjustment, notch increments, salary benchmarking project that we're undergoing, and then funding of for 12 additional vacancies that we were not previously able to fund due to budget constraints. The contracted services is one of the major components of our goods and services budget, which relates to the National Control Laboratory for vaccines lot release testing, We did identify cost savings, so there was a 9% reduction year on year that we could apply in 25-26. Overall operational expenditure increasing by 7%, and that's mainly driven by additional allocation to our core operations, such as inspectorate travel when they do the inspections, externally evaluated to boost our resources in doing medicine evaluations, and then also for medicine testing, storage, and distraction. There was a bit of a decrease on our capital expenditure, mainly due to some of the digitization processes that we had in the 24-25 financial year. We can go to the next slide. This slide shows the fee income per program, just to indicate where our main revenue is lying per program from core business. And 56% of our fee income is mainly generated by program 2, and it's related mostly to product retention fees and new medicine registrations. So the new medicine registrations and new renewals revenue stream that we've implemented now in February 2025 is the main drivers of the increased revenue, where we expect a 19% year-on-year increase. Program 3 relates to our inspectorate units, where we expect an 8% increase year-on-year, and Program 4 relates to clinical trial evaluations, post-registration amendments, and biological testing of medicines or vaccines. Program 5 relates to medical device license and their retention fees, and the budget for the 25-26 financial year were adjusted upwards as well based on our actual revenue that we generated in 24-25, and we did see a bit of a jump of revenue for 24-25 for Program 5. The next slide indicates the MTF budgets per program, being Program 1, the administrative functions, and from Program 2 to 5, the core business units. So our budget allocation is about 63% allocated to the core programs and 37% to the administrative program, and we expect a 2% increase on that over the MTF period. Program 2 to 5 are the core business programs, like I've indicated, and Program 1 providing support services to Programs 2 and 5, mainly related to facilities, ICT services, and governance. The main cost driver you will see for Program 4, or they've got a higher allocation for goods and services in Program 4, which is mainly related to the National Control Laboratory for testing of lot release vaccines. And then also in general, between Program 2 and 5, the cost of employment components are quite high, as our main cost drivers do relate to actual capacity within these units, being human resources. Thank you, Chair. Over to you. Oh, sorry, CEO, over to you.
Professor Helen Rees, Dr. Semende, that concludes your presentation. Am I reading it well?
Yes, that is correct.
Excellent.
Thank you. I mean, perhaps,
yes.
May I say a couple of final sentences, Dr. Tlomo?
Go ahead, Chair. Go ahead.
Thank you. So just a few things that I would like to say. I think overarchingly, from the board's point of view, we're very satisfied with the progress that's being made. Everything from the audits through to addressing backlogs, the executive being fully staffed, and so on. I think that we are making very good progress. And just so everyone is aware that the SAHPRA is now regarded, is held in high regard, not only in the African region, it is one of the most well-developed regulators in the region, but also globally. And people are seeking out participation from SAHPRA staff on many global committees that are relevant. The second thing is just to highlight again that we will be looking at the legal reform and bringing this back to you because the legislation definitely needs to be cleaned up, just to make it easier to function within. And the cannabis issue, just to reiterate, the reason we're emphasizing this is that I think very often there's a misunderstanding that SAHPRA regulates all cannabis matters, which is not true. In fact, we regulate the minority of products, and it's those that have a medical indication, that have an indication that would indicate that this is a medicine and can be used as such. Those we would regulate, but anything beyond that we would not regulate. And that would be the majority of products that we're now seeing on the market. In the future as well, we are going to probably come and talk to you more about the impact of artificial intelligence, not only on streamlining, as Dr. Semete said, operations, but we are going to see more medical devices utilizing AI as part of the product. And so regulators around the world are scratching their heads at the moment and saying, how are we going to understand and regulate these? And lastly, I think many of you will have read concerns about products, as Dr. Semete said, that are either counterfeit or substandard or being sold in the wrong places without oversight, which means we cannot guarantee their quality. So that is going to become, we believe, a bigger concern. But having said all of that, from the board's point of view, we're very pleased with the overall progress of SAHPRA. Thank you very much.
Chair, you may be muted if you're speaking. We can't
Yes,
hear you outside.
Mamkako, we've lost the chairperson. Can you please take over while I'm trying to get hold of him? Thank you.
I'll do that. Vuyo, am I?
We could hear a colleague speaking just now, but we've definitely lost the chairperson.
Am I audible? Kayako is speaking now.
Yes,
Yes, thank you.
Mamkako, the chair is back.
Okay, if he's back, he must carry on. Welcome, Chair.
Okay.
Yes, I'm sabotaged by Miss Machalamba, who keeps on knocking me off the line. But nevertheless, now I'm back. Thank you very much. Professor Rees, when you completed your input, I wanted to say this. It may be people like yourselves who were once upon a time junior researchers who are now at a very senior level, who can do a narrative and a write-up of where are we and where do we come from with what was called an MCC. That would be very key to write because now we are well recognized, but 15 years ago, it was not like that. It has not always been like that. There's a lot of hard work that was put by yourself and many other people who came before you to do this. So I would love to really wish that someday you won't really delegate this to the Department of Health. It will be yourselves who can really do a write-up for the country as to how did you get to where you are now. And that will be very key as lessons learned from this process. I really thank you very much for that. Now, let me recognize my members who would like to engage with their presentation. And hence, Honorable Mutubase, Honorable Van Staden, Honorable Dr. Carr, Leroux, Honorable Dr. Litlape. Now, Honorable Clark comes last. or just before another hand comes up. Let me get to those hands now and see. Start with Honorable Mutubatse, Honorable Van Staden, third one, Honorable Dr. Leroux, fourth, Honorable Dr. Letlape, fifth, Honorable Clark, in that order.
Okay, no, thanks very much, Chair. And again, welcoming the report that has been presented to us as a team. Mine is just one or two questions. I'm very keen on the AMA treaty. The CEO said that soliciting support. What kind of support do you need from us? Because I'm very keen on the indigenous medicine, and we're moving in a very slow pace. I did raise the same question with the Research Council yesterday. And what is the communication between the two of you in making sure that we move with the necessary speed around that particular area? And what is it that can be done also to fast track our research area and recognition of some of the medicines that we have in our country? Yeah, that's the question that I wanted to raise, Chair, if can be assisted in that area. Thank you.
Honorable Van Staden, thank you.
Thank you, Chairperson. Thank you for the presentation. We have a discussion last year around the availability of mpox vaccines, which was a problem to get into South Africa. I just want to know what is the current status on the mpox vaccines. And then my second question is around, maybe I didn't hear very clear, maybe it was touched on, but if we can get some clarity. I just want to know what measures are currently in place to eliminate the current backlog in product registrations and the approval timelines. Thank you, Chair.
Thank you, sir. Honorable Dr. Leroux. It's your opportunity, Dr. Leroux. Still drinking a glass of water. Honorable Dr. Letlape.
Thank you, Chair.
Really sorry, my computer froze.
You will come after Dr. Letlape.
Okay, he can.
Okay. All right, Dr. Leroux, come through.
Thank you very much, and my sincere apologies for that. My computer completely froze, although I could hear you. Thank you very much to the team from SAHPRA and for your presentation, and I just congratulations on the amazing work that you've done over the last few years to get this the organization to a position where you are very highly rated worldwide and are doing very important work. I just had two questions. One was just around I know that you've spoken about this quite a lot around cannabis, and I think that I'm just trying to understand, and I understand the rationale where you're specifically focusing on the health products that are sold and marketed as health product, but there are obviously also some products that are that are being sold to the public that have cannabis or THC as sort of as a for its hallucinogenic effects, and those are obviously don't seem to be regulated as well, and so there is some kind of medicinal effect, even though it is used as a recreational drug. And so I just want to understand why that distinction is there and why you're not helping for those products to be regulated, because of course the dose is very important, etc., and so understanding what could cause harm to people would obviously be important, and you're quite skilled in that area. So I just want to understand that process and the rationale behind that. The second question was just around looking at the budget and seeing the significant increase in fees and also the increase in cost of employment in terms of salaries going up. All of those increases are quite significantly above inflation, and so of course all of those fees and all of those costs will then be carried by the public. And so again, I just wanted to understand why those are, I think they were between 8 and 12%, and why they are higher than inflation, and how that has come about, because of course that is going to put pressure on manufacturers, and that will eventually be carried by the public. So just wanted to thank you very much.
Okay. All right. Aleklape.
Thank you, Chair, and thanks for the presentation. I just want to return to what Dr. Leroux has raised. I understand the issue of what your scope is in terms of marijuana. But when we have components from the hemp being put into food, and you had food intoxication from people having cookies. We've had an incident where people were given cookies and they were high and they went destroying property in a club. When it comes to that component, when the department has the responsibility for food safety, how is that going to be done? And is there a satisfaction that the agricultural department has the ability to deal with the defect? I understand the fact that, a dagga cookie is not a medicine, but just like we deal with food poisoning and the death of kids, how is that aspect going to be managed? And what would be ideal, given the competencies and the expertise that lies within SAHPRA in terms of managing that aspect? The second question would be, it's not really for you, it might be for the department, the challenge of not supporting local industry in terms of uptake. There have been concerns about not getting our vaccines from our local vaccine manufacturers. And given what is happening in the globe about people protecting their own industries and looking inwards, what would SAHPRA's advice be around those issues? Then you have the issue of asking for our support to sign up for the Africa Treaty. Why are we not signed up with the others? What is the impediment, and how can we help? Because we don't want to see South Africa seeing itself as part of Europe and not part of Africa, and thereby losing its strategic leadership position in the continent. So for me, it's something that you need to be assisted to do that. Then there's the issue where we were dominant, particularly in SADC, but a lot of the neighboring countries are having their own regulatory spaces. What is the level of cooperation? Because we don't want to see medicines being registered in Swaziland or in Namibia and then tracking themselves into South Africa. What are we doing proactively in terms of controlling and managing that space? What are the cooperative agreements with your counterparts, particularly in SADC? Do you have a SADC framework that protects us from those issues? And increasingly, we're now seeing that would be part of pharmacy cancer, but we're now seeing a lot of people selling prescription drugs even from the streets. What is SAHPRA doing around that aspect of prescription drugs? I mean, I've seen on television one of our citizens proudly saying, I'm not a healthcare practitioner, but I'm giving out Ozempic and I'm injecting people and they sort of prescribing. What are we doing in that space in conjunction with the Department of Health and the Pharmacy Council in terms of curbing those issues and protecting society? Thank you, Chair.
Thank you very much, Honorable Clark.
Thank you, Chairperson. I've just got a few questions. Please explain the downwards revision of the performance targets within the performance targets, as well as the change from percentages to total numbers to demonstrate performance.
We don't seem to be hearing Honourable Clark.
Yes.
Sorry, my I don't know why it went off my sound. Sorry, Chair. I'll just start again. I've only got 4 questions. If you could please explain the downwards revision of performance targets in the performance targets, as well as the change from percentages to total numbers to demonstrate the performance. And then, did SAHPRA benefit from any PEPFAR funding? If so, what is the impact of the US discontinuing this funding, and how is
Honorable Clark, come back.
Chair, I'm having the same problem you've had this week now. My sound keeps on freezing.
You are back now. We can hear you. Continue.
Okay. I'm not sure what was heard.
We heard you asking the PEPFAR impact, if there is.
Okay.
Yeah.
Okay, thank you, Chair. How will the entity deal with the risks associated with independent funding? And does SAHPRA have an ongoing court case on any matters? Also explain the allocation of legal fees for the past 3 fiscal years. Thank you, Chairperson.
Okay. No, thank you very much. Professor Rees, you'll have to come back again, because if some of us as members of Parliament and in this Health Portfolio Committee are still not very, very clear about the thin line between SAHPRA and Department of Agriculture when it comes to cannabis, we really need you to expand a bit, because we want to be able to be your spokespersons out there. This information is also assisting us when we meet such issues in the community. So I have a very basic understanding, but if you can strengthen it here, that would be very great. That is the only part I wanted to raise in your response to us. Thank you very much.
Thank you very much, Dr. Tloma and honourable colleagues. I'll ask Dr. Samete to give the lead and the answers, and then I will complement them. But we can explain to all the honourable members about the issues around cannabis. I think everyone shares Dr. Tlhapi's concern about abuse of cannabis. And in excess, this is indeed a drug that does have significant impacts, both on young people and indeed now we've discovered on older people when used in excess. So I'll hand over to Dr. Samete, and I will come in and complement on some of the questions. Dr. Samete.
Thank you very much, Chair. And I note there's a question on our finances, so our CFO will tackle that when we're done, and our CRO will also tackle the question on the backlog. I'll speak to the others. Let me start with the one pressing one at the moment. So when it comes to cannabis, and understand the question raised by the various members to say if the THC does have these psychoactive properties, why do we not then step in as a medicine regulator to oversee that? But it all goes back to what are you mandated to do according to the Act. And when you look at the Medicines Act, it does 3 things. The first is to say SAHPRA regulates all products that are intended to be medicines in this context. So if it's not intended to be a medicine, we do not regulate that. And why it says intended to be a medicine is because there's certain, that's the second point I'll raise, certain clinical data and safety data that we would require for a product that claims to be a medicine compared to a product that is a food, for example. And then the third thing, again, is around the legal prescripts. So for us, even though those products may contain cannabis, again, there are other cannabis varieties that have very low THC, such as hemp, which are utilized for industrial purposes. So you don't want to put the very stringent regulatory requirements that are for medicines on products that are not medicines and do not require that level of stringency, and which is a challenge that we set in a few years ago. And so with amending the schedules, with amending the regulatory requirements, we've now delineated all of that. So as we speak in the country is that if a product is intended as a food product and contains cannabis, it falls under the ambit of the Food Directorate within the Department of Health. They will then apply the relevant food standards to that, to oversee that area. If it is meant for industrial purposes, and it's typically hemp, which is very low in THC, agriculture will step in there and regulate that area. But anyone who is cultivating cannabis, whether it's for food purposes or for industrial, has to receive a permit and a license from the Department of Agriculture. And in the past, all of this used to come to SAHPRA, but it's now been moved to the Department of Agriculture because, again, we would apply very stringent requirements for what is to be used as a medicine. And there's a lot of products, as Prof. Rees said, the ones that are for medicinal purposes are actually a very small proportion of what we're seeing externally. And so everything else that's not a medicine does not fall under SAHPRA. What falls under SAHPRA are those that are intended to have a health benefit or are medicinal in nature. So depending on the concentration and the quality, it would be Schedule 0, what we call Schedule 0. But the minute it makes medicinal claims, if it's a CBD, it's Schedule 4. If it's THC, again, because of its psychoactive properties, it's Schedule 6. And so that's why there's now these stakeholders that would need to ensure that they oversee cannabis as per their respective mandates. Another important stakeholder is law enforcement in the form of the Department of Justice, and then the cannabis bill, which then governs how it should be used when it's used either for personal use or not. And so the complexity with cannabis is that it is regulated by different stakeholders. And for us to ensure that we have a strong handle on this crop is that each stakeholder needs to ensure that they effectively implement what is within their mandate and that we collaborate. There is a cannabis working group that has been put in place on the back of the Pakisa that happened sometime last year. And all of us as stakeholders are part of that and giving updates on what it is that we're doing. But we're not all moving at the same pace. And hence you have this distancia. But I can say with certainty that for us as SAHPRA, we've been very clear around what it is that we regulate, and when there's non-compliance, even with the limited capacity we have, we will then go out and ensure that those entities do comply, wherein they're utilizing it for medicines. So I hope this has assisted. And again, the other reason why you cannot overstep what is within your legal mandate is that those who are then done for within your mandate will challenge us legally to say, SAHPRA, you're now regulating products that are not medicines, which is what happened with the court case that was concluded in 2019 or so. So the next part that I'd like to speak to is around supporting local. So with supporting local sector, what I've indicated in the presentation is that we have put in place a policy for supporting local manufacturers. And what that will mean is that if you are a local company that is manufacturing products that are of public health need in South Africa, we will prioritize your application, and we will also not charge you high fees that we typically charge for priority applications, which means that our local industry will have quicker access to the market. And this applies for vaccines. So we're working very closely with the industry players that are manufacturing vaccines, biologicals, and other health products that are of public health need. I'll speak to the point now on the AMA Treaty. And you may remember that it did come to the Portfolio Committee and was subsequently then recommended to the state law advisors. However, there is a clause there that speaks to diplomatic immunities that the state law advisors were not comfortable with. And so it does need to be addressed. And so the National Department of Health is working with them, but it has taken quite a while. If you remember, the committee did look at the treaty with Minister Patla at the time. This is probably about a year plus ago. And so it's been stuck in this process. But again, as members have said, as we participate at AU level, it doesn't bode well. That's South Africa, which has one of the strongest, if not the strongest regulator on the continent, that we haven't ratified. And so we constantly get questions around, are there any reservations we have with the treaty itself, which is indeed not the case, because there are no material reservations we have with the treaty. So I'm just going to go through these questions. There were quite a few asked. I'll talk to the African traditional medicines. As indicated, we are working on these, and there's a framework that we will be putting in place for regulation of African traditional medicines. It has taken longer than planned. You know, over the last 2 years or so, since 2020, 3 years, we focused a lot on, you know, COVID, and only over the last year or two, we're starting to look at, you know, all the other areas. So, but it's something that we do have on our radar. In terms of collaboration with our neighboring countries, so yes, we do have MOUs, I think, with most of them. And we typically publish, you know, the agreements that we have with them. We communicate this to the public. And, you know, Zimbabwe, for example, Botswana, we've got Namibia, we've got agreements of collaboration where they're even relying on regulatory decisions done by SAHPRA. And at a SADC level, we have what we call Zazibona, which is a platform where products are submitted through this regional instrument, and the products are evaluated by our assessors at a regional level, and recommendations then made to the different countries. So I must say there's quite good collaboration with the different countries. We also have SAHPRA staff at the ports of entry, particularly the air and the sea ports, and we are working with Swaziland and Lesotho also on ensuring that we facilitate efficient movement of products through those specific land borders. And then on the matter of funding from, I'll just say the US government generally, we did have funding from USAID that was affected when we had the US government stop work order. That specific project has, however, subsequently been reinstated. There are other projects that have been affected and have subsequently not been reinstated. And for this, we are looking at talking to other partners and trying to see how we use any of our little bit of budget that we have to bridge the gap in those areas. But it's not a significant portion when you compare to our total external funding that we receive. And then in terms of prescription drugs, it is a challenge, and it all speaks to these substandard and falsified products, that we are seeing a proliferation of these. And at a point, we've got our inspectors out in different parts of the country. At the moment, I've got inspectors in the Eastern Cape because we had a whistleblowing report there that have gone to see what is happening there. And in all these cases, we would work with the police services. So it is a big problem for us in South Africa, and it does need that we strengthen our law enforcement and ensure that these criminal cases that we open are indeed finalized. That's one of the areas where we're battling, that we would open a criminal case and it takes many years for it to even reach conclusion. So in essence, while we act on these non-compliant providers, if the law does not make sure that it is fully carried through, they do in essence get away with this act. So we have to make sure that we work closely and we strengthen our law enforcement. And then on the downward revision and the change from percentage to numbers. So the reason why we change from percentage to numbers, you'll see it's primarily on the 2 targets, wherein we are of the view that when we start to measure actual numbers, it will give us a very clear sense of how much of the backlog we are clearing, and our CRO will speak to that. But for us, it was important that over this MTF period, for us to demonstrate that we're clearing this backlog and that we don't build another backlog, it is important that we measure these targets the way that we have articulated it. And we're already seeing it bear some fruits, really, when, it's just easier to measure. And then in terms of court cases, I don't have the information immediately with me as my colleagues present. I'll just look at some information. We do have some court cases. One is pending, one is around COVID vaccines. We still have 1 or 2 pending from COVID. We had 1 from cannabis, but I will look at that and give you more detail after my colleagues have presented, and also some of the amounts that we have spent on that. I must say, during COVID, we did have a much larger expenditure on these court cases because a lot of them were linked to COVID vaccines. This is declining, but again, regulation is quite a litigious area. So at a point, we are expecting that there will be some court case ongoing, but we try our utmost best to ensure that we operate as per the Medicines Act and ensure that we win. And a lot of these court cases we have won. So I'll pause here, Chair, and then maybe ask Rehat to comment on the budget, and then Tammy on the backlog, and then I'll ask Prof. Rees to come in on MPOX, and I'm happy to add if there's anything else on MPOX, Helen.
Thank you, CEO. On the question related to the increase in fee income, so we took about 2 years to do a comprehensive review of our fee regulation that was gazetted in 2020, in December 2020, so you can effectively say early for implementation in 2021. And we found that there were areas that were significantly under-recovered in terms of the services and the resources we have to appoint to deal with that type of workflow within SAHPRA. There were new revenue streams identified to align with the Act, like renewals or our new renewals processes. So therefore, you would see a higher than inflationary increase year on year, specifically in 2024-25 compared to 25-26. But also, historically, if you look at our prior financial years in the previous MTF period, we also were able to increase our outputs as we appoint additional staff and grow as an organization and enhance our processes as well. So it's a combination of increased outputs and then now, most recently, the increase of the fee regulation. On the cost of employment, increase of 12%. So this is not just a salary increase. Included in there is 12 vacancies. We do have a staff component that are professionally skilled and qualified doctors, pharmacists, and so forth. So they do have a bit of a price tag when it comes to them. And historically, we also did not have sufficient funding to fund some vacancies that were never funded before, that there never was a position in before. So we do, every MTF period, try to add on or reduce the number of unfunded vacancies as we progress and as the organization grows. And we need these resources to enable to achieve our mandates. But in the end, with our fee increases and the revenue generation, what we don't want to become is a burden to the state in the end. So we do need to make sure that we actually recover our costs, and we do it fairly. We do engage with industry on the justification for those increases. Maybe just to touch on the risk related to external funding, how we do mitigate it. We do have our eye on it. As we plan our budgets over the MTEF period, we also do take into account possibility of self-funding some of those positions. So some of our positions are funded by external funders to assist us with the funding gap that we have. They are contracted for employees, so mitigating that risk also. If we do not grow sufficiently in revenue, they are contracted employees. But as we do progress and as we do project, we try to absorb some of those positions when the funding expires. On legal fees, just historical expenditure, as CEO said, COVID was 2021, 2022, we're about 7.5 million. It came down to 5.5 in 2022, 23. But we did see a bit of an increase in 23, 24 and 24, 25 to around about 8 million. And our budget allocation is about 4.5 million over the MTEF period with inflationary increases. But we do are able to, as these legal cases do take sometimes a couple of years to come to finalization, they do actually add up in terms of costs. But as CEO has indicated, they're mostly regulatory in nature, and it's trying to implement some mandates. But with the carryover of these cases into new financial years, we are able to carry over some of the committed funds to these areas into the 25-26 budget. Thank you. That's it from my side.
Thank you, Rahad. Tammy? You are unmuted, but we can't hear you. It seems that Tammy is struggling. Let me comment on the court cases while we sort out that IT issue. So I've just quickly looked, Chair. So we have 2 cases still pending from COVID. We have 1 case pertaining to cannabis and our scheduling, and all of these are from 2021-22. And then the others, they are around the interpretation of the Act. And again, motivates why we need to make sure that we review the Act, or we overhaul the Act and provide a lot more clarity, because there are some sections of the Act that are open for interpretation. So if I could categorize them, that's what we have pending at the moment. Tammy, let's try again.
Can you hear me now?
Yes, we can.
Okay, sorry about that. Thank you, Dr. Tumi, and through you, Chair, I'll answer the question by Honourable Van Staden regarding the backlog and reduction in registration timelines. So this is a key focus for SAHPRA. We have internal tracking mechanisms, and areas that have where we see an increase in the backlog, we immediately try to re-engineer processes, example in our inspectorate department, and have our inspectors come back into the office and only do certain key critical inspections, so being agile enough. Secondly, we've had quite a few resources employed in some of our areas, such as the biologicals, medicine review, pharmaceutical evaluations, inspectors, and pharmacovigilance. The third aspect that we would look at is the intense focus on reliance, and where we will apply reliance to dossiers as indicated by applicants. The fourth area would be the use of artificial intelligence, where we are developing screening tools to take away from some of the admin work that our staff do. So we have the screening tools and eventually bioequivalence tools that will help us alleviate some of the resources to focus on actual evaluations. And internally, we have close tracking mechanisms and do deep dives in certain areas where we see unnecessary use of our internal resources. We would then engage with industry through the Regulatory Technical Forum, for example. Those are just the key highlights. Thank you very much. I'm handing over to you, Prof. Rees.
Thank you. Thank you very much. I'll answer just a few of the questions. First of all, Dr. Dlomo, Honourable Dr. Dlomo, I think you and I have been around since the beginning of SAHPRA, but I just would like to remind, I mean, you know, we're so full of bad news. I think that SAHPRA has been a good news story. I had the honour of chairing the board for the first board and now the second board. And we went from something that really was, you know, apart from legislation, a blank sheet of paper, into a legislated modern regulatory authority. We inherited from the Medicines Control Council a backlog of 16,000 products, some of which went back, the oldest I think was 1977. And that backlog was cleared a few years ago. And we learnt lessons, as we've just heard from Ms. Gopal, that we learnt lessons about how we avoid backlogs in the future, and we continue to learn. But I take your point that we should actually look at lessons learnt and perhaps write an academic article, because it has been something that I believe the country could be proud of. In terms of AMA, Honourable Mutabatsi, I just want to underline what Dr. Samete has said. We would love to sign that agreement. And we are probably one of the few African countries that are lagging behind. So if there is something the Portfolio Committee can do to accelerate this, there's just one clause which is not really relevant to us about diplomatic immunity in the agreement. It's not relevant for South Africa. We are lagging behind by not signing it. It will put us at the AMA is going to be, as many of you have heard of, the European Medicines Agency, very powerful, very effective, very pro the public. And that's what AMA is ambition to be. So we would love to be signed up to it. In terms of Mpox vaccines, I'll talk to this in my capacity. I'm the co-chair of what's called an incident management team. The Director General of Health declared this an emergency when we had an outbreak last year. We've had a second outbreak this year. We have got access to vaccines through the African CDC. We have 10,500 vaccines now coming in. 3 priority provinces who've had cases in the first outbreak. And we will be targeting particularly the MSM community. So that is what's happening with the Mpox vaccines. And the application from the SAHPRA point of view was fast-tracked. So anything that, like an outbreak where you need urgent access to medicines, will automatically go into a fast-track procedure, as on the assumption that there is nothing in the country that would substitute it. So I think that the other one is the not getting vaccines from local manufacturers. I think Dr. Samete's answered that, but I just want to emphasize that where there are products, again, including vaccines, they will be fast-tracked if there is an urgent need or if they're unique. So vaccines are seen as a priority product. And in terms of the World Health Organization's evaluation of SAHPRA and its ability to review vaccines, we will probably get what's called a maturity level 4, which is the highest recognition you can get as a maturity level for our ability to review vaccines. So that again is a feather in the team's cap. Thank you very much.
Okay. Thank you very much, and your team. I think your success story will be a very good case study to write up, and really let's learn from it. I want to stimulate you by just telling you some of the things that people in Africa are saying about us. It was the South African Nursing Council that educated countries, Tanzania, Botswana, and all countries in the east of Africa, to have what is a nursing council-like type of a structure. They didn't know that they could regulate the profession, assist to guide the profession to sort out and really be protective to the society. So whenever you go to those countries, they talk very highly of the Nursing Council of South Africa for their support. I think this case study will then go a long way towards strengthening the resolve, what they do there. Because of course, you remember the pioneer regulatory body in the continent. But where you come from, it just didn't happen overnight. There was a hard work that you guys and some of the forebears put into it. So it will be greatly enhanced and encouraged by this write-up as a case study. I'll phone you again in 2 years' time and find out how far are you with this work. But thank you very much. We can now release your care.
Thank you very much.
Thank you very much.
Honorable members, I really want to, as a closing comment, thank you very much for your dedication over the past 2 days that you have worked so hard, engaging and really enriching our understanding of a lot of these issues from presentations that have been made by our institutions. I hope we are successful. Ms. Machalamba will comment after me whether we are successfully getting the department to join us tomorrow at 1 o'clock instead of 2, so that some of the honorable members who have indicated their travel for tomorrow afternoon can then be free to do so, and the bookings have been sorted out. Maybe as we close, Ms. Machalamba, let me find out if they have agreed to a 1 o'clock meeting instead of 2.
Yes, they have agreed, Chair.
Okay. Honorable members, this meeting will be held virtually. We will wish to be finished by 4:30, so that if we are booked from East London, a 5 o'clock flight, you can really be able to make it. We hope to see you. I'm glad about the response I've been getting from Ms. Makubane, that some of the colleagues have really been able to arrange their weekend that we are almost encroaching into, and make sure we do this very important, impactful visit to Tembisa Hospital. May I request that we also extend that to Rahima Musa Hospital, as advised by Honorable Clark, but we'll request the MEC to meet us up at Rahima Musa, so that we don't have another third venue to go to, and then maybe finish off our visit by that meet and greet with the MEC and that board. Thank you very much, colleagues, and have a good evening.
Bye-bye, Chair.
Thank you, Chair.
Thank you, Chair.
Thank you, Chair. Bye.
Bye, everyone.